Hello and welcome to the Health and Government Operations Committee. We have a slight modification to our regular process today. The sponsor has asked for several of the bills on today's agenda to be withdrawn, so they will not be heard today. There are several bills that overlap in their content and purpose, which is to increase regulations on the activities of pharmacy benefit managers and include the contracts that PBMs have with self-funded insurance plans in the current regulations. Some of the same people have signed up to speak on two or more of these bills. Those bills are House Bill 755, 1014, 1015, and 1274. We will hear from the sponsor of each of those bills and their favorable panels first. Anyone who has signed up on more than one bill can choose to speak on both bills at one time for 4 minutes or for 2 minutes on each of the bills. The committee will have a chance to ask questions after the favorable panel on each bill. Upon the conclusion of the favorable panels on all 4 bills, we will hear from the 4 unfavorable panel members who will each have up to 4 minutes to speak on all bills. The committee will have the opportunity to ask questions of this panel and follow-up questions if necessary. The rest of the bills on today's agenda will be done with our usual committee process and times, 5 minutes for the sponsors and 2 minutes for each witness. With that, let me tell you the bill order for the day. Again, we will hear 755, 1014, 1015, and 1274 in the modified rules that we just described. And then we will hear 973, 1007, and 610. The first bill is House Bill 755, Pharmacy Benefit Managers Prohibitive Actions, Delegate Krebs. Hi, Delegate Krebs.
You're on mute, Delegate Krebs.
Oh, sorry about that.
No problem. Let's get started. Welcome.
Thank you. My hand got laid on that. For those that are new to the committee, we've had bills in for a number of years on pharmacy benefit managers and some of the impacts they've had on our independent pharmacies. And we all in this committee love our independent pharmacies. They're part of our communities, and we want to make sure that they're given a fair playing field so that they can continue to operate. And many have gone out of business, unfortunately, over the years that we've been discussing some of these bills. So this bill today, House Bill 755, basically would say what prohibitive actions are there for pharmacy benefit managers. And for many years, we were told that we really could not regulate any of these things, but we had a Supreme Court decision that came out a little over a year ago, that said that yes, we could. We could indeed. It was the Rutledge decision. And as a result of that, the Maryland Insurance Administration came out with a report this year, basically telling us what we could or could not do in this committee. And it's called the Report of the Maryland Insurance Administration on Rutledge versus Pharmaceutical Care Management Association and its impact on our bill, on our laws. So we do have the authority to be able to regulate some of these things. And in fact, many other states, 24 states have already implemented some of these bans or prohibitive actions. So what does this particular bill do? On this bill, it would add to the statutory list of prohibitive acts by PBMs, which are the pharmacy benefit managers, that they be prohibited from doing. And why do we need the bill? As I said before, it will prohibit certain unfair, anti-competitive, anti-consumer practices we believe, by the pharmacy benefit managers. It would not allow spread pricing, and this will be described later by the rest of the panel, where a PBM reimburses a pharmacy for a lesser amount than it's paid for dispensing the drug by the insurer or prescription plan. The second thing it would do is make sure that the plan networks, a PBM should be required to let any willing pharmacy participate in a prescription drug plan if the pharmacy is willing to accept the terms and conditions of the plan. It's called any willing provider. Our consumers, our constituents should have the choice of where they get their prescriptions filled, where they choose. It also would require the copay should be the same for all pharmacies. It can't just be different from one pharmacy to the other. And mail order pharmacies, it would say mail order pharmacies should not be a plan requirement. This should be the choice of the consumer and not a requirement imposed by the pharmacy benefit managers. The consumer should be allowed to decide what they want to do with that. There are 2 amendments that have been offered. One's in your packet, one is still being worked on, one is from the Independent Pharmacies of Maryland, that's fine, and the one from the Maryland Retailers Association. In concept, we're fine with that, we just have to get it done. And again, many states have moved forward with some of these prohibitions because we now have the Rutledge decision that says we are able to do that. So let's hope that we are able to move forward with some of these things to allow their independent pharmacies to be able to compete and to continue to provide the services in our communities that they've done for many, many years. So I'm going to turn it over to Jim Doyle, followed by Brian Hose, Kelly Locklear, and then Deepak Kami. Thank you, Madam Chair.
Absolutely. So Mr. Doyle, first of all, there's 2 minutes left on the sponsors clock, so you can use that. In addition to that, we have you signed up on this bill as well as 1014. You can testify just on this bill right now and come back and do another 2 minutes on 1014, or you can do all of your testimony right now, whichever you prefer. Mr. Doyle, do you want to testify twice, almost 4 minutes on this one, and then another 2 minutes on the next one?
He's on mute.
Mr. Doyle, I think you're on mute.
Okay.
There you are.
As I said, I think I would like to deal, even though there is overlap between the bills, I think I would like to deal with each one individually.
That makes perfect sense. So we'll give you your 2 minutes as well as anything left on the sponsors clock, which is 1:51. So go right ahead.
As Delegate Krebs indicated, the bill is really to deal with certain unfair and frankly predatory practices by the PBMs in this state and frankly around the country. Let me just, I think to put the bill in context that might be helpful, let me quote some of the descriptive language that our Attorney General Frosch, has used in amicus briefs that he has recently filed in federal court actions that I think describe what's going on with PBMs. And here is some of the language that has been used by Maryland, which has joined in those amicus briefs along with a number of other states. So for example, those amicus briefs state that PBMs are particularly susceptible to self-dealing and unfair advantage. PBMs harm pharmacies, consumers, and states. PBMs harm pharmacies by lowering reimbursement rates and favoring certain pharmacies. PBMs steer businesses away from independent pharmacies and toward PBM-owned or affiliated pharmacies. This is Attorney General Frosch basically saying PBMs have gotten out of hand in terms of their power and that something needs to be done in terms of further regulation. And that's what this bill is designed to do, to deal with some of the worst practices of PBMs. Let me just, one other thing in terms of the context of this bill, to show you what local independent pharmacies are up against. There are only about 3 PBMs that cover all of the markets, 80% of the markets in the country. Take the biggest one, for example, CVS Caremark, which is a PBM. Now, CVS also owns its own mail order and retail pharmacies. But if you just look at the CVS PBM division, putting aside the pharmacy divisions, just look at the PBS division of CVS. Their fiscal report that came out about a month ago indicated revenues of $153 billion, up 8% from a year ago. Of course, independents are nowhere near in those kinds of positions financially. But again, it just shows you how PBMs can take advantage of these things that the Attorney General has talked about to contribute and to gather immense profits and revenues from their practices. Now, this particular bill is designed to deal with those kinds of practices that are frankly unfair. And the bill deals with, in the main, it deals with 4 of them. The first one is the practice of spread pricing, where the PBM will charge the insurer or the plan network a certain price for drugs, and then it will reimburse the pharmacy that it's set up in its network. It will reimburse the pharmacy a lesser amount, and the PBM pockets the difference between those amounts as its revenue. Now, don't forget, when it does that, the PBM plays no role in manufacturing these prescriptions. It plays no role in dispensing these prescriptions. It plays no role in any of it. Yet it determines as part of its revenue stream that it's entitled to take a cut of these dispensing fees.
Thank you, Mr. Doyle. I'm sorry, I have to wrap you up because I have to have the same rules for everybody today. But so that we use both of your timers already. Yeah, but you will have an opportunity to speak on 10:14. So if you want to just finish your thought right now, and then we'll see you again on 10:14.
I'll finish my thought. Just now, the other provision that's a main provision is any willing provider. 26 states in this country have enacted any willing provider. It's pro-consumer, it's pro-independent pharmacies who have great difficulty into getting into these networks established by PBMs. And we also deal with a couple of the other issues, copay and mail order. But we think these are all issues that the Attorney General in his language in the briefs has basically tried to put his finger on.
Thank you very much. Next, we will hear from Deepak Kinney, and you have 2 minutes on your clock. Thank you so much.
Thank you, Honorable Chairwoman and committee members. I appreciate the time. I represent Hillcrest Pharmacy and Compounding in Frederick. It's a very small pharmacy, started in 2017 and currently on the brink of closure. And it is not a joke. These PBMs have these practices which lead to low reimbursement, anti-competitive practices, which have pushed us this far. However, I want to take time to thank you all for doing what you can to help us out. Your previous year's efforts led to a elimination of transmission fees, where the PBMs used to charge up to 50 cents per prescription that they didn't have anything to do with the consumer. So we've saved thousands of dollars, but they have used these spread pricing practices that Jim just talked about to take all that money back. And our reimbursements overall have still gone down. Even though we saved on the transmission fees due to your efforts, they have taken those efforts away because of these spread pricing practices. Spread pricing is an opaque practice that leads to anti-competitive marketplace. There is no way for insurers, the consumers, or the pharmacies to influence pricing, only the PBMs. There is no way you can have any meaningful effort or effect by any laws as long as there is spread pricing in this marketplace. I urge that you guys support these measure, because spread pricing is one of many ways that PBMs can negotiate with insurances. But if you stop this, at least they might bring some transparency into this whole affair. Thank you, everybody, for giving me the time, and I appreciate that. And hope that you pass this bill.
Thank you so much for your testimony. Next, we have Brian Hose. And Mr. Hose, I'll ask you the same question I asked Mr. Doyle, because you're signed up on, I believe, 4 of the bills today. Would you like to do 4 minutes now on all 4 bills, or do you want to do 2 minutes on each of the bills? Whichever you prefer is fine.
I think 2 on each is going to be easier just for me logistically.
Perfect. Let's hear your testimony on 755 then.
Thank you. Members of the committee, Chairwoman, we've been here for many years. We at Epic Pharmacy represent right now 134 pharmacies in Maryland, and we are in support of this bill for many of the reasons that we've been telling you over the years. I'll pick up where Mr. Doyle left off. The copay parity section, where PBM can't use copays to incentivize their own pharmacies, is one that has been challenging for us. If patients are given the opportunity to save money by using a PBM-owned pharmacy, they might as well be directing them there and forcing it, especially with some of the differences in copays that we've seen. This action has been one that has caused many of our customers to be forced or be driven to go somewhere else just because of their financial situation. They can't afford to spend more money to come to see us. No mandatory mail order is the last of the four then, and that is something that again has been challenging. There are plans that the PBM will force that beneficiary to use mail order. It doesn't give them the right to choose their own pharmacy. It doesn't make it fair for them to have a relationship with a pharmacist that's local to them. Or sometimes in many cases, any pharmacist. It's very difficult to use a mail order pharmacy and get to speak to one of the pharmacists, much less know them on a personal level. We know that because we get those calls all the time asking us to provide support for prescriptions that were filled by mail order. This bill is kind of a catch-all as far as PBM regulations. If you look at the second page of my testimony, you'll see that NCPA has done some work here. And in the last 10 seconds, I'll just say that if you look at it, the states without PBM licensing authority and that don't regulate PBMs have seen higher increases in health insurance premiums than those that have PBM licensing authority and regulations. So the fact that this will raise costs just hasn't borne itself out when they look at the states that have done it. So I'll end it there.
Thank you so much. I really appreciate everyone's willingness to respect our clock. Final panelist on this panel is Kaylee Locklear. After we hear from Ms. Locklear, we will go to questions. Kaylee Locklear.
Good afternoon, Madam Chair and honorable members of the committee. Kaylee Locklear here on behalf of the Maryland Chain Drug Store Association. And we are here in full support of efforts to help protect our brick and mortar retail pharmacies by ensuring PBM transparency and improving patient access to a consumer's chosen pharmacy. I would direct you all to page 4, lines 8 through 10, as we want to ensure a loophole is closed in this bill with regard to copay. And we've been working with the proponents, the sponsors, thank you, Delegate Krebs and DLS, to craft this language that was referenced earlier. So let me provide an example of how this would play out as the bill is currently written. Say a patient's preferred brand prescription copay is $30 for a 30-day supply. A PBM can actually allow the member to get a 90-day supply of that drug at mail order for a $30 copay, but still only allow a 30-day supply of the same drug at retail for $30. So in essence, the PBM who does this would still be compliant with this bill if it becomes law, because the bill only says a PBM cannot charge different copays to retail than they do to mail, but it isn't based on the actual daily supply. So we've been working on this. We actually proffered 4 different solutions that you all have before you in writing. I think we made a breakthrough yesterday as there is West Virginia language and statute that we would just need added while preserving language concerns community pharmacies have. So with all that said, I think we look forward to working with you in subcommittee and we urge a favorable report. Thank you.
Thank you so much. Do we have questions from the committee for the proponents on this bill? I don't see any hands up. I just want to make sure. I'm going to give you guys a second. And I will remind you that Delegate Kipke. Go ahead, Delegate Kipke.
Thank you. Just a quick question to Brian or Deepak, but only one of you. Some of the people that represent the PBMs have been proffering that Maryland independent pharmacies licenses are growing in our state. And so if you get the total number of licenses last year versus this year, and going back to 2019, you'll see that the number of licenses have increased somewhat. They use that as an argument that independent pharmacies are doing just fine. And from a real life perspective, people who do this for a living, can you shed some light or provide us what your thoughts are on that?
So, I mean, I'd be happy to talk to you about it. I know that in just the preliminary data that I've heard from the Board of Pharmacy is that in 2021, they use a fiscal year from July to July. So just, in the last 6 months of 2021, they had 34 closures when they had 34 closures in all of 2020. So I know that there have been some pharmacy closures. Now, the opening of stores, it does not seem to me like the stores that we're seeing open are large, healthy, profitable independent pharmacies. These are very small operations. If you looked at the script volume and even the dollar volume of sales of the independent pharmacies in Maryland, it continues to shrink. That number may fluctuate as far as the number of stores, but the dollars involved is continuing to shrink, both by reimbursements and by the number of prescriptions filled and the number of dollars that are represented by those.
Just for a little more clarity, there's an advocacy group paid for by the PBMs that has people who do what you do, riding around in BMWs and having a great time. Can you be a little bit more personal? Can you tell me what does this mean? You express the challenges to what everyone faces, but what does this mean? When I talk to some pharmacists, they make me think things are dire. Can you tell the committee what this experience is like for many independent pharmacists in the state?
I can tell you what it means for us. We discontinued a residency program, which gave us an additional pharmacist in our store to help train them and provide enhanced services to our local community. So we had to cancel that. It was an expense we couldn't afford anymore. We had a technician leave right before the pandemic that we weren't able to replace. So through all of the extra vaccinations, all of the extra work that we've been doing, we have not been able to staff the store at a level that we would like. The reimbursements on many prescriptions are still below cost. I'd say over 50% of the ones that we're seeing are below our cost. And you just hope for one of these prescriptions where you make good money to keep the door open. Some days you feel like you're just working to lose money. It is really challenging. I do not own a BMW. I haven't been in one in a long time, but I certainly know what it's like to struggle. I mean, we had a wholesaler mishap over the last month where some credits were applied for some invoices. I won't even try to get into it, but McKesson has the strangest accounting practices I've ever seen. But they were going to draw money from an account in a way that was abnormal. And just because the timing was different, we were going to have trouble making that payment. And we've had instances over the past couple of years, even as much work as we're doing for COVID, and you would think that would generate more revenue, paying the bills. And it's not easy. It is definitely not easy to be an independent pharmacy owner right now.
Thank you very much for your answer. Delegate Johnson.
Thank you, Madam Chair, and thank you, panel, for bringing us this information. On Delegate Kipke's question, when the PBMs say that it's a healthy environment for independent pharmacies and talk about the applications for new pharmacies, are they including the closet pharmacies that are opening up in doctors' offices where they have another source of revenue to supplement that so they can have a pharmacy but do not provide all of the community resources that an independent pharmacy would? The best person to answer that?
I could tell you that physician dispensing would not be included in the Board of Pharmacy counts for pharmacies. But that doesn't mean that a pharmacist, the pharmacy could be a traditional pharmacy in that it's run by a pharmacist and is also in a physician's office. So I don't know if those are high numbers or not, but I know that the physician dispensing, where the physician is doing the dispensing, there is no pharmacist involved, would not count in that count.
Thank you. I know that a lot of them do have pharmacists in those little small pharmacies. That's why I asked, but thank you. And thank you, Madam Chair.
Absolutely. Delegate Krebs.
Thank you. I guess this question is for Brian. Brian, in anticipation of the opponents every year come in and say this is going to raise healthcare costs. And I don't have any testimony in the file from them this year because they never give us anything in writing any year. We never have anything on paper to look back on, but that's always their oral testimony to us. So I'm sure that's what they're going to say. But then you gave us a sheet that tells us on the back of your testimony that controlling PBM conflicts of interest does not raise healthcare costs. And it talks about the states that have now done these things between 2015 and 19 about the about the premiums and the lack of effect on them. Can you expand on that? Because that's usually the argument, is it's going to make healthcare costs go up. Can you expand on that?
Yeah, that is the argument always. And this was a very short fact sheet that was put out by NCPA. I can work to get more information from this study to the committee after the fact if you're interested in it.
Well, just overall, we like the executive summary, which this is. And the executive summary is
that, in states, the nationwide average is 16.6% as far as the increase in healthcare costs. We've seen in states that have more PBM regulations that was almost a third of a percent lower, whereas in states that had none, it was almost 0.4 higher. So the states that regulate PBMs have not seen the national average increase in premiums, whereas states that do not regulate PBMs have seen a higher than average increase in costs. And that would, lead one to believe that when PBMs are allowed to do whatever they want, the cost goes up faster than when they're controlled with laws like this.
Thank you. And I want to thank all the proponents for giving us written testimony. It's so helpful to the committee to have something to look at and read instead of just trying to remember what was said. Thank you.
Thank you, Delegate Saab.
Thank you, Madam Chairman. Brian, just a quick question. I just want to make sure I heard you correctly. Did you say that you would have to fill 50% of the prescription that you fill at below cost?
Yeah, no, when we're looking at them coming across our screen, many of them are below cost, and it's challenging for us to deal with. I mean, some of these below costs are 50 cents or 10 cents, or the ones that drive me nuts are the ones that work out exactly what our cost is. It's like you're filling this prescription for 0.0. But many of them are big, and we see losses that can be hundreds of dollars. And in those cases, a lot of it is for branded special order products for us, things that may not be on our shelf, and we have to make a decision: are we going to stock these products? Are we, is this something that we can fill at a loss that big? I mean, these are really challenging things. We're not allowed to refuse to dispense things, but certainly our inventory is it can only be products that are not huge losses for us. So I mean, we're in a difficult position every day with some of these things coming across. And yeah, I would say that 50% of them are below our costs.
And typically there's also obviously refills. So you continue, it's not a one-time loss. It's every month when the patient comes back to refill, right. You're consistently losing the 50, money on that. Thank you. I appreciate it. And I'm sorry. Thank you, Madam Chairman.
No problem. We are going to hear from the opponents on this bill after the next three bills. So we're going to hear House Bill 1014 next, which is Delegate Kipke, Pharmacy Benefit Manager's definition of a carrier, ERISA, and purchaser. Delegate Kipke, welcome.
Thank you, Madam Chairman and members of committee. House Bill 1014 builds on the work of the committee from last session. As was mentioned by Delegate Krebs, there was a Supreme Court case, which some believe the most conservative justice and the most liberal justice wrote. They both wrote opinions mirroring each other in support of basically the idea that state legislatures have the right to regulate PBMs, even the ones that had formerly been believed to have been ERISA preempted. So we passed legislation last session. We were one of the first states to do it. It's now moving around the country in a positive way, that in areas related to reimbursement are laws that have been passed over the years, things like banning GER and DRE and all these different things apply to all licensed plans that are executed in the state of Maryland. The law that we passed asked the MIA to also look at other areas of the code beyond reimbursement as it relates to the regulations of PBMs, and to report back to us as to what else could be applied. And basically, you would think that proponents of regulating PBMs wrote the report, because the MIA basically said they think anything essentially could be applied and not be ERISA preempted. So this bill essentially seeks to do that. It seeks to regulate all aspects of PBMs that are currently in statute that don't impact plan design, but actually impact other things. And it's mostly related to the relationship between the PBM and the pharmacists. So I don't see how any of this could in any way harm consumers or increase costs to consumers. So with that, I'll conclude and just ask you to take that into consideration as we debate the bill. Thank you. Oh, there are some amendments. There are some technical amendments I'll mention that we will work out. They were actually drafted incorrectly. So we're still working out to fine tune that with collaboration between the MIA and the Department of Legislative Services, but we'll get that right as we get into subcommittee. Thank you.
Thank you. We have two panelists signed up on this bill, Jim Doyle and Brian Hose. So you'll each have your own 2 minutes and you can share amongst yourselves however you so choose. The 2 minutes and 27 seconds left on Delegate Kipke's clock. Jim Doyle can go first. Jim, are you on mute?
I'll be brief because Delegate Kipke has adequately, very adequately summarized this bill. This is simply trying to do what I think really should have been done last year, which is to fully implement the Rutledge decision from the Supreme Court. Instead, we had a bill that sort of went halfway, implemented part of Rutledge, but held back on other parts because it wasn't clear at that time as to what the extent or what the holding of Rutledge exactly was. But the General Assembly wisely said to the Maryland Insurance Administration, we want you to do a study on the scope of Rutledge and report back to us. And it's done that. And it's completely agreed with the position that we have taken, which is that Rutledge allows broad regulation by the state of PBMs. And that's exactly what this bill will do. And I'll also just add before concluding that not only has the Maryland Insurance Administration adopted basically our position on this, that broad regulation is permissible, but also the Attorney General, as I indicated in the earlier bill, has called for greater regulation of PBMs. We have the Eighth Circuit Court of Appeals federal decision that supports us. So as far as I've been able to determine, every relevant legal authority that has looked at this issue has concluded that, in fact, we do have the legal authority to do what this bill is attempting to do, which is to bring all ERISA and non-ERISA PBM plans under the regulation of the insurance commissioner under the same terms. Thank you.
Perfect timing. Let's hear from Brian Hose.
All right, thank you. This is a bill that we talked about in great detail last year. We worked in subcommittee for a long time. I hate to use the words "I told you so," but we said that we thought that this bill should be applied broadly, as it was in Arkansas and as it has been shown to be in the Eighth Circuit in North Dakota. We knew that the Rutledge decision was more than just the reimbursement model for PBMs. It's become very clear, as Jim pointed out, with the AG decision as well as MIA review, that Rutledge certainly was not just about reimbursement. So we've seen other states now that have gone down the same path. I think that we certainly believe that the bill should be what it was when we started last year, in that it just includes everything, all the PBM regulations that have been passed by this committee through the hard work over the years should be applicable to both ERISA plans and non-ERISA plans. And I don't think there's a whole lot more for me to say there other than, this certainly would help independent pharmacy. We would go into these hearings and we would sit in subcommittee hearings, and the PBMs would say, well, this only represents 20% of the book of business in the state because all the ERISA plans are excluded. And we said, we don't believe that's true, but at the time, that was the governing principle, and that's what we were set to deal with. We've since, had this Supreme Court decision, and we really feel that these laws, if good enough for that 20%, are certainly good enough for the other the other plans as well. And we would like to see this expansion happen. So I'm happy to take questions.
Excellent. Thank you so much. We already have a question from Delegate Cullison.
Thank you, Madam Chair, and thank you, Brian and Jim, for being here. So I just have a question in terms of, I think, the goal here, I think, is to keep our independent pharmacies healthy. And I am interested if you could take a little time and explain exactly how the regulation of the ERISA plans puts more dollars in the pockets of independent pharmacists. So like what aspects of these regulations actually puts money in the pockets of the independent pharmacists?
So sometimes it isn't dollars. Sometimes it's the fairness of it. Sometimes it's when you look at the way that things are treated with regards to pharmacy audits, or with some of the other provisions that we've regulated PBMs over the years. It's not necessarily writing a check to independent pharmacy, but it's making sure that PBMs are forced to treat us fairly in all of these plans, not just 20% of these plans. A lot of the provisions that we've passed throughout time, as far as regulating GER and BER and the direct and indirect remuneration fees, were at the time only applying to the fully insured marketplace. We certainly believe that all of the regulations of the PBM relationship between themselves and pharmacy should be covered under Maryland law, not just the fully insured network. And it's not necessarily writing a check to independent pharmacy. We have some bills that would help force reimbursement to be at a more fair level. This is more about leveling the playing field and making sure that we have an opportunity to compete in the marketplace fairly.
May I follow up, Madam
Sure.
Chair? Just so, like you mentioned audits. So tell me exactly, how does the audit affect the independent pharmacists? How the fact that we have not in the past had these ERISA plans followed the current regulations. Help me just understand how the audits help.
I mean, it simply
Something
means
like that.
that they could do whatever they wanted. There was no regulation. There was nowhere to go to complain. When you filed a complaint with the MIA, what you got back from them was that this plan is an ERISA plan. It's an employer-sponsored plan, and we have no jurisdiction over it. And so where the rubber meets the road is that you have no way to force the PBM to treat you fairly. Now the MIA would have jurisdiction over these other pieces as well. And when there is a discrepancy, when the PBM does something that they're not supposed to be able to do, the MIA would no longer be able to send a letter that says we don't have jurisdiction over this plan. You're on your own. Tough luck. It would be, we're going to evaluate it and make sure that, the law is followed, and we're going to take action if we need to.
Great. Thank you. That's what I needed to hear.
Excellent. Thank you so much. So that is the end of questions for the proponents on panel for Bill 214. Again, we'll hear the opposition after we hear the next two bills. For House Bill 1015, which is Delegate Karen Lewis Young, pharmacy benefit managers, prohibitions related to reimbursement and use of specific pharmacy requirement application. Delegate Lewis Young.
Thank you, Madam Chair. Good afternoon, committee. I do have a bill to present to you that is a variation on the theme of the day. HB 1015 intends to strengthen current Maryland anti-steering laws by repealing existing exceptions that are harming competition, incentivizing waste, and rendering specialized patient populations more vulnerable. For those of you that are new to the committee, I'd like to define pharmacy steering. It's when PBMs steer customers to pharmacies, including mail order and specialty pharmacies, with whom they are affiliated. For example, they require a higher copay, and if the patient obtains the drug from another non-affiliated pharmacy, they pay a higher price. So as the law stands, specialty drugs, mail order drugs, and medications dispensed at chain pharmacies with more than 15 stores are exempt from state prohibitions on patient pharmacy steering. Not only did these exceptions undermine the intent of the original bill, but they also represent a step backwards in terms of the state's ability to protect patients from harmful pharmacy steering practices. About 9 other states already have passed legislation banning various patient steering practices within state regulated health plans. Like Maryland, about half of these states specifically call out specialty and mail order drugs in their statutes. However, unlike Maryland, they do it in a way that specifies additional protections for the affected patient populations. Maryland is the only state that explicitly excludes specialty medicines and mail order drugs from anti-steering protections. This exclusion is enabling anti-competitive practices and incentivizing pharmacy benefit managers to develop steering policies for specialty medications and mail order drugs, since these harmful policies would be under the full protection of existing law. It's really important to disincentivize these policies for specialty medications and mail order drugs, since these harmful policies would be under the full protection of existing law. In summary, there's a way to reduce these bad practices and put us in compliance with best practices from other states. This bill is intended to not only strengthen our current law by providing some cleanups to statute, but also enable the passage of other potential PBM legislation that's been heard before this committee. Thank you very much for your time and attention, and I'd like to pass on my remaining time to Dr. Ferozvi.
Excellent. Thank you so much. So let's hear first from Kashif Ferozvi.
Hi, how are you? Thank you so much, Chairman Pendergrass, Vice Chair Pena-Melnick, and members of the House Committee. My name is Kashif Ferozvi, and I'm a medical oncologist practicing in Maryland Oncology Hematology Silver Spring location. Thank you for the opportunity to provide supporting testimony on House Bill 1015, which we view as a critical step for extending Maryland's anti-steering laws to protect the state's most vulnerable patients. Patients with complex, chronic, and life-threatening illnesses like cancer need specialty drugs, and they need timely access to high-quality, coordinated care with their medical team to ensure the best possible treatment outcomes. Delays cost lives. I can't be any more clear about that, whether it be delays in obtaining the drug or delays in a dose adjustment. I work with all my patients to develop highly personalized treatment plans that include oral specialty medications like chemotherapy, alone or in combination with IV medications as part of a complex treatment protocol. It is essential to reduce barriers to access and coordinated care, not to erect them, by forcing patients to obtain these important medications from disconnected PBM-aligned pharmacies. Advantages of oral agents can be significant for a patient. However, these benefits are undermined when steering policies remove patient choice. Pharmacy steering for specialty medications like oral chemotherapy lead to several negative consequences. Number one, delays. These drugs require lengthy authorization processes or copay assistance applications, which require constant communication between the provider office and the patient. PBM pharmacies struggle to even make contact with the patients through the maze of phone tags, where patients often don't even pick up the phone for fear of spam or some other unexpected caller. This inevitably results in delays which impact outcomes. Number two, waste. As PBMs do not know what is happening to the patient outside of asking if they are still on the drug, They regularly automatically refill drugs to patients with no awareness of whether the dose has to be changed or if the patient is even still on the drug. These drugs are very expensive and can cost over $10,000 a month. I regularly receive patients returning drugs that were erroneously sent to them, not knowing what to do with them. This happens quite often. Number 3, harm. These drugs are oral, but they're not benign, and they require close coordination with the patient's changing medical condition. PBMs do not talk to physicians and struggle to communicate with patients. PBMs do not have access to patients' EMRs and are blind as they manage these medications. I've been practicing for over 20 years, and to this day, I have never once received a call from a PBM pharmacy about a patient's condition, yet receive daily calls from our pharmacy team in our medically integrated pharmacy who are cross-checking with me and reviewing the patient's medical records. There is no comparison when it comes to patient safety. As the Maryland anti-steering statutes are written, exemptions for specialty and mail order drugs only serve to incentivize protective methods of steering and promote the development of anti-competitive practices that ultimately hurt patients. In 2020, only 3 PBMs processed nearly 80% of prescriptions nationwide. It is crucial that this state place meaningful guardrails that protect patients from anti-competitive practice. It is so important that the committee consider passage of HB 1015 to remove the exemptions that are standing in the way of equal protections under the law so that we can pave the way for stronger and more effective patient protections in the future, not just for my patients, but for all patients in the state of Maryland. Thank you.
Thank you very much. Let's hear next from Allison Rollins.
Hi, good afternoon, members of the House Committee. My name is Allison Rollins, and it is my privilege to be testifying in support of HB 1015 today. Some of you may know me as Senior Government Relations Manager at the U.S. Oncology Network, supporting Maryland oncology hematology. However, today I come before you as a chronically ill patient residing in Rockville, Maryland. The testimony I'm about to give is solely my own and does not reflect any official position of my employer or the practices that I support. Today, I'm just Allison, and this is my story. So I've been chronically ill with asthma and autoimmune issues since I was 5 years old. But now as an adult, what plagues me the most is my Crohn's disease. Crohn's is an autoimmune disorder that can attack all parts of a patient's digestive system, and for me, it truly does. In 2017, I was working on an entry-level job that paid very little. And at the time, I was spending about a quarter of my monthly pay on medical costs and had no savings to speak of. I had one of the worst flares of my life that summer, with so many ulcers in my mouth and throat that I could not talk or eat. So my doctor prescribed a compounded liquid called Magic Mouthwash that would help heal my sores. I called my plan and asked if they would cover the drug at the specialty pharmacy down the street from my house, but their answer was no. I could only get the drug from a pharmacy that was 40 minutes away, was only open during the workday, and wasn't accessible by transit. I didn't have a ride, so I had to take off work and spend $100 that I did not have on Ubers to get out there, pick up my drug, and come back. And I seriously considered not even doing it at all. But I needed to eat, so I sucked it up and I put it on a credit card. For those of us with chronic illnesses, patient steering policies for specialty medications often mean that we have to go outside of our provider support systems, outside of our communities, and sometimes outside of our budgets to make sure that our needs are met. In the 8 years that I have been on specialty medications to treat my Crohn's, I've never had a PBM call me to help with my care coordination, despite signing up for their programs. I've had drug interactions, harm from toxicities, and even been stepped off of my drug onto a biosimilar without any patient education. I wasted so much money on unused, unneeded mail order drugs that can't be returned, just gathering dust in my hall closet. The reality is that I am my own care coordinator, and current Maryland law protects the PBMs if they make policies that take that control over my treatment choices away from me.
Thank you very much for your testimony. We do appreciate it. Next, we hear from Caitlin McDonough.
Good afternoon, Chair Kelly and Chair Pendergrass and members of the committee. Caitlin McDonough on behalf of the U.S. Oncology Network and Maryland Oncology and Hematology in support of House Bill 1015, which, as the delegate describes, removes exemptions in Maryland's current anti-steering statute for specialty drugs and medications dispensed by mail order. I'll start with thanking Delegate Young and the committee for taking steps to implement protections for patient choice in pharmacy back when the original anti-steering language passed in 2019, and respectfully request the committee's consideration of extending those protections to the most vulnerable patient populations in the state, those with chronic conditions and those who rely on specialty medications. Since that legislation passed, the role of pharmacy benefit managers has grown exponentially to the point where, as other witnesses have mentioned, 3 PBMs are processing more than 80% of prescriptions nationwide. The increased proliferation of PBMs has led Maryland, among other states, to implement anti-steering policies like the legislation before you. The difference being that other states don't exempt the patient groups in most needed protections and service options. In fact, some of those states actually pull out specialty drugs for increased anti-steering protection under their laws, as Delegate Young mentioned. Expanding these protections will allow patients suffering from chronic conditions to access their treatment in a timely manner from a trusted provider of their choice, the same ability that is already extended to other less vulnerable patients in Maryland. In preparation for today's hearing, I did have the opportunity to review the 2019 hearing from the original legislation, and noted that the committee repeatedly asked for patient perspective on these anti-steering policies, in addition to pharmacists and PBMs and insurers. And I think you will see in your packet today that the advocacy groups for patients with chronic conditions that are most impacted by this bill are in strong support, and we join them in urging the committee's favorable report. Thank you, Madam Chair.
Thank you very much. And finally, for this panel, we have Brian Hose.
Thank you, Chairwoman Kelly. We certainly support this. We've supported further anti-steering laws with specialty medications over the years. I'd like to point you to the Maryland Department of Health PBM audit by Myers and Stauffer that was submitted in 2020, and you can see that when a PBM pays themselves, we believe that's because of the steering towards these specialty meds. The average payment from a PBM to its own wholly owned pharmacy is around $148.89. When the average payment per claim to a pharmacy that is not owned by that PBM is only $47.69. I think that most clearly states why PBMs are so protective of these specialty meds, because they know that by steering them to their own pharmacies, they're able to generate additional revenues for themselves. This is one of the loopholes in Maryland law where they have been able to force profits into their pockets. And we would love for this to be a level playing field. We've said it in the past. We think patients are the best judge of who can best provide care to them, whether that be their oncology practice, whether that be their local pharmacist that they have a relationship with, or whether that be a mail order pharmacy. But certainly they should have the right to choose. They shouldn't be forced into a money-making scheme for the PBM to line their own pockets. And frankly, it's long overdue here. And we're happy to have such great support from other members. Just briefly to comment on Allison's testimony, we have so many patients that need special meds like this, that need us to do things for them that may not be standard. And I can completely understand where that type of service and that type of special need is one that is best served by a local pharmacy that you have a relationship with. And we certainly support that. In fact, I'll be making some magic mouthwash when I hit the counter today. So I appreciate you.
Thank you so much for your testimony. Do we have questions for this panel? I'm going to give the committee a second. I don't see any hands up as of yet. Okay, so let's move on to the, just kidding, Delegate Krebs. Hello, Delegate Krebs, go for it.
Obviously, these bills are near and dear to my heart, and those of us who have been here for a while. But Dr. Keshif, first of all, thank you, and also, I guess, Allison, for sharing your perspective. It's a perspective we really haven't heard, but you gave us some very specific reasons about the whole relationship and with the local pharmacists versus with the PBMs and the bureaucracy of the PBMs. And I wrote a bunch of it down, but could you provide that to us? I don't know if you have it written out, but it was very good testimony about some of the specific things we can't quantify necessarily on this committee in a dollar and cents, but some of the waste, access to care, delay in getting prescriptions and not being able to talk to a human being. If you could get us that testimony, it was very strong testimony, and I really appreciate that.
Sure, absolutely.
You bring a different perspective than just the pharmacy. Obviously, I think we know this anecdotally, but your perspective analysis was very good.
No, absolutely. I'll be happy to send that to you. And it's not uncommon for us to have delays in initiating chemotherapy because we can initiate the IV, but the oral drugs are in the black hole waiting for the PBM pharmacy to deliver the drugs. And so patients will show up and I say, did you get the drugs yet? And they say no. And then we have to figure out what to do. Do we give the IV now or do we delay everything a week? This happens quite often, unfortunately.
No, thank you. Thank you. Ms.
Delegate,
Kipke?
I'll just add the practice submitted written testimony under my name, under Caitlin McDonough. So it should be in your packet under my
Okay,
name.
I didn't
from
see it. Thank you.
MOH. So
And
sorry.
And Dr. Keshe, this committee, Dr. Ferozvi, this committee is the one that authorized the, mandated oral chemo years ago to be paid for because it was such an important thing for us to do. And we don't want any delays in our patients getting that. So thank you.
Thank you. Thank you so much.
Excellent. Delegate Cullison.
Thank you, Madam Chair. And Dr. Ferozvi, I had a question. You referenced the pharmacy that you have currently I don't know if it's in your particular location or practice, but so does your oncology network have a fully licensed pharmacy associated with it?
It's through our practice and through our medical practice. We have 3 pharmacists and about 6 pharmacy techs all working with us to manage our patient population, both in terms of the intravenous chemotherapy, actually more than 6 pharmacy techs, I apologize, about 10 pharmacy techs, managing our intravenous chemotherapy plus our oral dispensing pharmacy medications. But it's all through our practice, not as a separate retail pharmacy.
But no, I understand, but it's a licensed pharmacy, correct?
Yeah, through our practice, yes.
Okay, so what you're asking for is that you be able to dispense the drugs from your licensed pharmacy of your network, is that right?
Yes, to be able to, exactly.
And you believe that that is currently not allowed?
We are not able to provide for government payers, we can, but not for some of the commercial payers.
You can for government, but you cannot for self-insured, is that what you're saying?
Right. Yes.
I mean, not self-insured,
Private.
the fully insured. Okay. All right. I need to follow up on that because I was under a different impression. So thank you, Madam Chair.
Absolutely. I looked like Caitlin McDonough had something she wanted to add to that. Are you okay, Caitlin, or did you need to add something?
No, I think Dr. Ferozvi answered it. I think the only thing with this particular legislation, even in circumstances, I think where they could dispense, it's kind of a matter of whether you're being steered away, so it's not necessarily an outright prohibition, but maybe instead, kind of limiting that choice in other methods, I think would be this legislation, but it obviously has broader implications than just that circumstance. So.
Thank you very much. Let's go on to the final bill before we hear the opponents of these bills. House Bill 1274, which is Delegate Kipke's bill. The title is Prescription Drugs, Pharmacy Benefit Managers and Purchasers, Federal 340B Program. Delegate Kipke, welcome back.
Thank you, Madam Chairman and members of committee. In doing some research on this program, over the interim, I saw a bunch of red states have passed a similar bill, but then I saw Michigan just passed the same bill as well. So any opportunity for us all to come together is always welcome. I included some testimony in your file as to what Michigan did, and I direct your attention to it. I don't know if Steve Weiner was able to join yet. He had indicated that he would try, but he's traveling today. But in his absence, Brian Hose is on, and I'd like to just defer all of my remaining time to him, as I think this is a new subject for many members of the committee. Thank you.
Absolutely. So let's hear from Mr. Hose, and you have all of Delegate Kipke's time as well as an additional 2 minutes if you need it.
Before Brian begins, one thing. Different pharmaceutical manufacturers have expressed a concern about one aspect of the bill that we do not have any issue with. So we do have an amendment that addresses their concerns. And with that, we're all on board. Thank you.
Great. Thank you so much. Now let's hear from Mr. Hose.
Thank you. When you look at me for this bill, I want you to think Steve Weiner, because Steve is a 340B contracted entity in the state or in the city of Baltimore, and does a great service to patients with HIV in that arena. And 340B pharmacies are one of the complexities of the way that the drugs are provided to patients. In this model, for those of you who don't understand, the drug is provided at a very deep discount to a pharmacy, who then provides it to a contracted entity who gets paid for that drug, and then the difference between the cost is used to essentially fund these programs. I mean, we see these contracted entities being strictly for underserved patients, but they get much of their funding from this 340B relationship and this discounted drug cost as part of the program. So what pharmacies typically do is serve as the conduit for patients to be able to get these drugs at no charge to them, so that they can continue their care. These are by no means patients who can afford these medications. These are, indigent, underserved, in Steve's case, many homeless, that really require this type of care. What we've seen from the largest players in the 340B market, surprise, surprise, are CVS Caremark and Walgreens, as they have jumped into this marketplace. But what we've started to see is some pharmacies that also do 340B have begin to run into issues with the PBMs in the way that they are treated. Those pharmacies are given are asked about whether they're doing 340B. They're in some cases excluded from networks because they are a 340B pharmacy. They're required to contract on their own. They're not allowed to contract with their PSCO. There's lots of ways that the PBMs have tried to limit this. Obviously, they're in that same space, so it would benefit them to push for other pharmacies out of that space. And it seems like the actions that they take are anti-competitive. And this bill and the ones that we've seen passed in other states really tries to protect both those pharmacies that are doing this, but in the end, ultimately the consumer of these pharmacies, which is really the indigent population that needs this level of support and relies on this system to provide care. And hurting that this network in any way certainly hurts those patients. And we would ask that the committee help protect these patients that are the most vulnerable. And I think you'll hear some testimony here later from a couple folks who are very involved in that process and understand exactly what patients benefit from these 340B programs and can be more specific with comments about that. But I'll yield my time to them.
Great, thank you so very much. So let's hear from Philip Marsiglia. I know I saw you here. Philip Marsiglia, are you available to testify?
I am.
There you are. Okay, go right ahead.
My name is Philip Marsiglia. I'm the owner and pharmacist of South Baltimore Pharmacy. I want to thank you for allowing me to testify in favor of House Bill 1274 with amendments by Epic Pharmacies. The South Baltimore Pharmacy is the only pharmacy in Cherry Hill community of Baltimore City, and we've been here for 45 years. For 30 of those years, we've served as the 340B contract pharmacy for Family Health Centers of Baltimore, a federally qualified community health center which serves uninsured and underinsured families in our community. During that time, the pharmacy, through the health center's 340B program, has provided low-cost medications to thousands of uninsured patients. In addition, the pharmacy has generated millions of dollars, that's over 30 years, in revenue for Family Health Centers of Baltimore through the 340B prescription drug program. The benefits to the uninsured and to the Family Health Center patients was the intent of the 340B program. And the millions of dollars that went back to the health center are operating funds that the federal government and state government doesn't have to spend to support these centers. As was said previously, and these dollars, by the way, are dollars that are in essence contributions by the drug companies. willing or unwilling, they are contributions to the system, and it was specifically designed that way in the 340B program. So what we're experiencing is the PBMs trying to restrict our networks.
I think there was a few seconds left on the sponsor clock. Is that right? If you want to go ahead and finish your thought, go ahead.
Sure. So we're at times paid lower reimbursements, or we're asked questions about where we're purchasing the drugs. And these really have nothing to do with the 340B with nothing to do with the PBMs. It has to do with the 340B program.
Great. Thank you very much for your testimony. The final panelist on this panel is Nora Hoban, who signed up favorable with amendments.
Good afternoon, Madam Chair and members of the committee. My name is Nora Hoban, and I am the CEO of the Mid-Atlantic Association of Community Health Centers, also known as MAC. MAC is the federally designated primary care association. And with that responsibility, we support Maryland and Delaware Community Health Centers, or FQHC, to ensure that they have access, to ensure that they can provide access to comprehensive primary care. Federally qualified health centers serve as medical homes, delivering a host of services to Marylanders most in need. Physicians, dentists, therapists, and other care delivery team members, they work together under one roof, coordinating care and treating the whole person. So too are the social workers and care coordinators that connect patients with additional services, and they also remove barriers to care. Maryland's health centers provide care in medically underserved areas, regardless of insurance status or ability to pay, and 65% of patients are Medicaid beneficiaries or the uninsured. The majority of patients are from disadvantaged populations, whether because of race, ethnicity, education, vocation, or poverty. And health centers are nonprofit. They are community directed, and they serve over 300,000 Marylanders. The 340B program is central to health centers' ability to make prescription drugs more affordable. And the funds also help expand access to needed services such as substance use treatment, dental care, transportation, and more. And while the 340B is a federal program, the federal statute does not protect from pharmacy benefit managers' pickpocketing practices. 17 other states have taken similar actions and implemented state laws, and about another dozen states are drafting bills as we speak today. Please support House Bill 1274 as amended by Epic Pharmacies, and thank you for your time.
Thank you so much. That concludes the testimony on this panel. Do we have questions from the committee? I'm giving you a second to raise your hands, but I don't see an Delegate Cullison. Delegate Cullison, go ahead.
You had to give me 2 seconds, Madam Chair. But yeah, can you hear me?
Sorry.
Okay, there we go. I just needed 2 seconds. Thank you. Thank you, Madam Chair. I have to tell you, I have been trying to understand 340B programs for the last year. So, and I've been unsuccessful so far, but I want to understand the intent of this, bill, and not necessarily how the program works, I guess. So, and I'm not sure who the right person to answer. Maybe Brian, you are, except that you're not Steve, and maybe the delegate can. But if I'm understanding that, so the 340B program is administered by a federal government agency, not a PBM. So if I understand that part correctly, but maybe not. So what the concern is that PBMs that a pharmacy might work with in order to discourage a pharmacy from working with a 340B program, they may be putting practices in place that make it hard on the pharmacist. And what this bill is trying to do is prevent those practices. Am I understanding the bill correctly?
Brian?
Sorry, there we go. When the screen flips, I can't find my little window. Yes, it is to prevent that. And we've seen PBMs want to drop pharmacies from networks based on their 340B status. And again, we believe this is just an anti-competitive thing. That these PBMs also have pharmacies in many cases that are participating in these 340B networks. I know specifically, and how the process works, Phil would probably be a better answer for you, but that is the gist of it.
Yeah, no, I'm just trying to understand the bill itself, and I think that's what you're trying to do. It's those practices, right? Okay, thank you, Madam Chair.
Absolutely. Any more questions for this panel before we move on to the panel of opponents? I don't see any more hands up. So let me make sure the committee knows we'll be hearing the unfavorable panel in the following order. We'll hear from Mike Johansson, then we will hear from Kimberly Robinson, then Matt Celentano, if he's here, I'm not sure if he is, and then Camille Fesh. And we will be generous in terms of leeway for questions, just so folks. Oh, Delegate Hill, did you have a question for the previous panel?
I did. I just had a hard time finding.
All right. Well, they're still here. Go ahead with your question.
Thank you. I'm kind of stuck. I know you were just explaining to Delegate Cullison. I'm just looking at the first part of the bill. The first page, it says, before allowing a beneficiary to use a mail order pharmacy that participates in the 304B program, a PBM manager or purchaser shall obtain a signed waiver from the beneficiary stating that the beneficiary is not required to use the mail order pharmacy. Can someone just explain, because it's hard to get into the rest of the bill, who is signing for who and how is that to be done?
The goal of the bill is to ensure that homeless people who have serious health conditions, who are getting treated through a federally qualified health center or healthcare for the homeless, or one of these places that who are in an agreement with the federal government in this 340B program. These places connect with pharmacy that's nearby. And so what we're trying to do is ensure that the patient that's being cared for is in control of where they get their medication. So what we're seeing from PBMs is they're steering the care for financial reasons to a place where they make more money, whether it's their own, the mail order pharmacy that they own, or a brick and mortar pharmacy that they own somewhere else. So this puts the control and the power in the hands of the patient, who we believe, especially in this vulnerable population, needs to be getting that medication as easily and most conveniently as possible to keep them in compliance with their medical needs.
Okay, and just to follow up, if I may, Madam Chair.
Sure.
Sounds like the right goal. When it says the PBM where the purchaser shall obtain a signed waiver, in this population you're talking about, is this an impossibility? I mean, in other words, you've got a homeless person. When does the PBM or the purchaser interact with them to get the waiver?
Basically, it puts the onus on the PBM to change where the person is getting their medication.
Okay.
So they're in sort of a managed care arrangement where they're getting their health care taken care of at a federally qualified health center, who is, I don't want to say holding their hand because I don't mean to sound disrespectful at all, but they're helping collaborate their care. And so they have around the corner, in this case, it happens to be Mount Vernon Pharmacy that we all know so well, but to put it in perspective, he's right there and he has relationships with the providers. So that patient is getting what they need right there. What's happening is the PBMs are saying, no, that's not the way we want to do it. We want you to get it from this mail order pharmacy. So they're directing it away from the patient's wishes. So what this bill is saying is the patient can get it mail order if that's what is in their best interest. But the PBM has to get that person to affirmatively agree that that's the way they want to get it. So it doesn't prevent it from happening. It keeps the power of healthcare in the hands of the person who needs it. And in this instance, in many instances, it's a collaborative way of doing it, where you have everything, the pharmacist there, the provider, they're all in a coordinated manner. So it just keeps the power in the hands of the consumer.
All right, thank you. Thank
Okay,
you.
Delegate Kaiser.
Yes, thank you. My question for Delegate Kipke, I'm certainly new to this, and everything about pharmacy benefit managers blows my mind. But so a more simplistic question, I'm hearing from others or the opposition that some of this legislation would increase the costs. What do you say to, what is your reply to that?
Well, from all the bills that we've heard so far today, there is nothing that requires the pharmacy to get paid more. So there is nothing in any of this that would say the PBM needs to pay them more. They just want a fair opportunity to continue to deliver the service that they provide in the healthcare arena. To be blunt about it, there are other states that have taken more aggressive action than Maryland, red states and blue states, and healthcare costs have not gone up there. In fact, we heard in recent testimony, West Virginia totally changed their model of how they procure pharmacy, and healthcare costs dramatically decreased. Last year, we had a study, or the year before, I lose time with COVID. In Maryland, we learned that we were getting hosed with this spread pricing, where the PBMs were pocketing $70 million that nobody even knew was going on. We assumed that was going to pay for the treatments that people needed, but instead they had this I think really a borderline illegal practice of just pocketing huge sums of money, and so it's almost like whack-a-mole. We're trying. It'd be great to have a comprehensive way of improving all of this, but we are sort of reacting around the country to practices as we learn about them, and to put up some guardrails against one particular entity, which is the most profitable in all of this, who, in my opinion, does the least, and that's the PBM.
And then a follow-up, Madam Chair.
Sure.
Is it your understanding, Delegate Kipke, because again, I'm trying to wrap my head around all this, that these PBMs kind of happened within the market and that any limit on them is limiting the free market? How much I know about PBMs could fit in a thimble if I had it.
As my office neighbor, I'd love to spend some time with you to talk about it. I attended a virtual NCSL meeting about this subject, where everybody there was sort of railing against how PBMs are becoming this monopoly that's very profitable. And I attended a virtual ALEC conference where everybody said that PBMs were becoming this monopoly and a profit center motivated by profit. In my opinion, they are a third-party administrator that also should work at negotiating the best deal for who's paying the bill. But unfortunately, I believe it's become a scenario where their motivations are profit, which I'm all for profit, but who they are serving, I believe, has weighed too heavily towards their own profit center, and they're not doing what is the fiduciary duty for which they are supposed to exist. So it's been complicated. This really began when PBMs, who should and do provide a valuable service, began to integrate with, they bought pharmacies. And when that happened, you're basically the payer, who also owns pharmacies, is now the payer for other pharmacies. And so it creates this sort of unhealthy imbalance in the healthcare system. And so we could talk a long time about this, but it is complicated. But I do think it's intentionally complicated too. This doesn't have to be so complicated.
All right, well, you can bring lunch to my office and tell me all about it.
All right, let's move on to the opposition panel. As I was reminding the members, they're each going to get 4 minutes to talk, and then we will use some leeway in terms of questions because we want to make sure that their position on all 4 of these bills is well understood. First, let's hear from Mike Johansson.
Thank you, Madam Chair. Good afternoon. Mike Johansson on behalf of the Pharmaceutical Care Management Association. We do represent the PBMs. There's a lot kind of in this conversation, even with the 3 bills that weren't introduced, there's a lot here. Let me start with a basic comment about what a PBM does. Just like an insurance carrier establishes a network of doctors and hospitals, works with the purchaser, who could be the state employees health plan, it could be Under Armour, and they develop a benefits package for the Under Armour employees or state of Maryland employees. And basically the insurance company in that situation where they're not really insuring it, they're basically the TPA, they're paying the claims, right? Negotiating the prices with the doctors, making sure that when the patient sees a doctor, it's a covered service, they reimburse the doctor. It goes back to the books of the state health plan. The state health plan is the ultimate payer. Same thing with the hospitals. Here we have rate setting for hospitals, so they don't have to negotiate the rates. But the point is, if an enrollee gets a covered service, they get it. The PBM does the same thing with respect to prescription drugs. Contracts with pharmacies, contracts with specialty pharmacies. Is it a covered service? How much is the pharmacy agreed to be paid in order to dispense that service? And then they work with the purchaser on the purchaser ultimately paying the claims, and the PBM gets an administrative fee. And in some cases, if that's the arrangement with the purchaser, a spread pricing arrangement, that's part of their compensation. PBMs are no different than carriers. 20 years ago, the carriers actually did the prescription function in addition to the medical function, born out of the exact same issue. If you think PBMs are nefarious, you're basically saying every carrier is in the same situation. You're saying that whatever relationship, and I'm just probably going to stick on this because I think the merits of the bills will kind of speak for themselves, and there's others behind me. But if you believe that the PBMs who are serving the same function as a health insurance carrier are wrongly motivated, that they aren't honest with their purchasers, the state health plan, Under Armour, whoever the purchaser is, then I'm not sure we can explain much more to you, because that is exactly the same service we do. In medical side, the state of Maryland has never passed an any willing provider law, meaning every doctor gets to sign up with every insurance company. You know why? Because it's bad for healthcare. It raises costs. The Federal Trade Commission confirmed that any willing provider makes it no incentive for doctors or pharmacists in this situation to give their best prices, because they don't have to. They're in the network without even worrying about that. That's the Federal Trade Commission. They look out for consumers. They aren't against consumers. Mail order pharmacy, the same issue comes across. If you have mail order pharmacy in your network, it's an option. Whether the purchaser decides to mandate it, which in some cases they can, unless this bill passes, you're going to get a better price. If the purchaser says, hey, PBM, go out and find the pharmacies that will give us the best price, charge us less for filling that same prescription, and if it includes mail order, why, if you're the purchaser, wouldn't you tell people to do that? You know who pays the purchaser for the health plan? The people who are in the plan, right? So state employees, Under Armour, whoever it is, they're paying the costs. Why would the purchaser, the state of Maryland Department of Budget and Management, why would they overtly say, oh, let's just have every network, every pharmacy that wants to come in, because it's going to cost us more money, but the employees will pay it. They won't care. That's not true. So every one of these things that we're going to talk about, and there's a big number bill when they want to be paid directly more, you talk about any willing provider, banning mail order, disincenting mail order, disincenting certain chains that are willing to do it at a better price. Anything that they do that limits what a PBM can do to control costs doesn't cost the PBM $1. It costs the purchaser $1 and everybody who pays those premiums. There's a lot here, Madam Chair, but we've got some other people that can address it, but I'm happy to answer questions when that comes up.
Thank you very much. Next, let's hear from Matt Celentano. Oh, wait, no, sorry, Kim Robinson. Kim Robinson is next.
Wait, you said I'm next?
Yes, ma'am, sorry.
Okay, so hi, Kimberly Robinson on behalf of Cigna. With 4 minutes, I'm going to go fast, and I apologize for that. While the debate about the scope of the Rutledge decision rages on, some commissioners do take a different approach to it than Maryland does, and does not agree with Maryland's conclusion. So I do think you're going to continue to see some debate around what exactly is the scope on that. I think that the court was actually pretty clear on what it talked about, and even the MIA's own report does not go as far as the proponents say that it does when it comes to where it believes there were some limits and what that's going to look like. I think the problem is that a lot of this conversation misunderstands the relationship between clients and PBMs. PBMs do not require clients to limit their networks, to mandate or incentivize mail order pharmacy, or require that they use or dictate any particular pharmacy or engage in disease management or specialty management. Those are the choices of purchasers. And I think to Mr. Johansson's point about understanding what roles PBM plays, I'm not sure the last time the committee really stopped to take a step back to make sure that there was a universal understanding of what PBMs do or how they do it as you continue to legislate how that works and what happens in those relationships. These bills are very different than the reimbursement issues contemplated in Rutledge or even the Webby decision decided by the Eighth Circuit. Those provisions are one set of things that the court justified under the Rutledge decision, but these do a lot of things that do not necessarily align with how either of those courts decided. And when it comes to the ERISA expansion, I hope that the committee would be thoughtful about passing bills that will have a clear cost implication on municipalities, county governments, and Maryland businesses who've never been within the state's regulatory reach, and generally not watching what the committee does without engaging with those entities in a fair and transparent way. In addition, every ERISA plan won't be under this bill, only those that are situs in Maryland, because states are responsible for the companies that are in their state. So pharmacists will still find that given that Maryland has a small footprint when it comes to large corporations, those with employees here will be under the laws of their state and continue to have a patchwork of experience. Because my time is short, I'm going to try to run through some highlights in each of these bills as fast as I can. House Bill 755 bans spread pricing for carriers in Maryland. You got a somewhat inaccurate description of what spread pricing is. I would love to be able to talk to you about it a little bit further. But even here in our own Medicaid plan that bans spread pricing for itself, because as a purchaser, they can make that decision, their costs went up as a result of that. And in this particular bill, it only applies to carriers in the fully insured market. So you're telling your health plans who aren't here asking you to ban spread pricing that you're going to take it upon yourself to do it for them, when it's not going to change the experience of pharmacies. It will just change the cost of carriers. It also contains an any willing provider provision. And as Mr. Johansson just referenced, the FCC has repeatedly identified that to drive healthcare costs up. That's their study, not ours. The prohibition on mail also is unnecessary because Maryland already has a prohibition on mail order in the commercial market. Again, this bill is commercial only. It's duplicative, but written differently than your existing law, so it's confusing why you would want to say the same thing in two different places in two different ways. Carriers already can't do it, therefore their PBMs don't do it for them. And that law has been on the books for more than 20 years. The experience that anybody has with mail order is not happening in the space that this bill is covering. In addition, House Bill 755, 1014, and 1015 conflict on the issue of how specialty management is addressed. At the end of the day, the law still allows carriers to do it. And so if you ban it with the PBMs, who are not the plans who are deciding to do specialty, you still have a law that says carriers can do it. So it's also confusing because you will be creating conflicting statutory provisions on what is currently a statutorily permissible program for your carriers. And then finally, House Bill 1274 related to the 340B program is concerning. It is drafted completely differently than the bills in other states. Can I just finish this one thought, Madam?
Absolutely, please do, please do.
So much. It's drafted in a way that differs from how it's drafted in other states. It talks about 340B networks, and that's not how we do that. We don't have a 340B network. We have pharmacies who themselves are participating in the 340B program. And so from a PBM's perspective on trying to figure out how to implement this, we find it challenging. It also has provisions that actually treat 340B pharmacies, therefore, significantly more favorable than other pharmacies. We have supported language in other states that create an even and non-discriminatory playing field, and would be happy to talk about what those bills look like. And lastly, this is a federal program, and we are expected on behalf of the Medicaid MCOs who participate to identify claims that are under 340B because those claims are ineligible for other discounts. And the only way to know that they're ineligible for the other discount is to know that they got the first. And so there's a conversation that needs to be had about that, because to provide the discount on top of the discount is prohibited under the Federal Public Health Services Act. Thank you so much for indulging me for the extra few seconds. And of course, I'm here to answer any questions the committee may have.
Thank you so much. And we're going to hear from the final two panelists, but I'll let you know, I'll give you a question on spread pricing so you can explain that to us further once we get to questions. But let me hear back now from Matt Celentano.
Thank you, Madam Chair, members of the committee. My name is Matt Celentano, here today on behalf of the League of Life and Health Insurers and AHIP in opposition to these bills. I wanted to start real quickly with our opposition to Senate or House Bill 755. We think the main point here is that this is not really a PBM bill. It's a carrier bill, and is that as they are the purchaser in this legislation. The only entities being impacted here are the health plans and the state health benefit plan. The prohibition on spread pricing essentially for health plans only, and there are no plans here today asking for this. Also, the spread has no impact on pharmacist reimbursements. We're not sure why this is even being proposed. In addition, it's been shared with me that some of the plans seek out spread type arrangements as they can maximize the savings for their particular groups. Also in 755, there's language in 1611B2 we interpret as any willing pharmacy, which is obviously a concern which you've heard from the prior two panelists. It removes the incentives for any pharmacy to join our networks, which carriers are actively looking to expand. These types of measures would also threaten long discussed network adequacy regulations on network sufficiency developed by the MIA. Any willing pharmacy measures have the opposite effect of their intent. You heard Ms. Robinson and Mr. Johansson refer to the FTC commission letter to CMS, but the FTC made it clear that, quote, any willing pharmacy provisions threaten the effectiveness of select contracting with pharmacies as a tool for lowering cost. Requiring prescription drug plans to contract with any willing pharmacy would reduce the ability of plans to obtain price discounts based on the prospect of increased patient volume, and thus impair the ability of plans to negotiate the best prices with pharmacies. Turning to the next bill, for decades, state laws relating to health benefit plans, including prescription drug benefits, have only been applied to fully insured health plans subject to regulation by the MIA, and not plans exempted from federal ERISA law. We understand the Rutledge decision has changed that landscape, but it has not changed the fact that proponents are now trying to mandate changes to plan design. It's very different than what I think the intent is. By extending the provisions of prior PBM law structure to self-insured plans, these proposals will restrict the opportunity for health plans to reduce pharmaceutical costs in their space. They will also come as a shock to these businesses that most likely have no idea these discussions are taking place and could see extreme drug sticker shock if the bill moves forward. We're also opposed to the bills that eliminate specialty pharmacy. These providers provide a niche service with specialized training and product that does not belong in a normal pharmacy space. Some drugs require special handling. In the case of some biologics, they're quote unquote alive. The extensive and separate training for these facilities is appropriate to be kept in the settings where they are now. I think you've heard the effectiveness of coupling disease management with specialty pharmacy in the past, especially from Care First, who does not own a PBM. The insurance article already allows it. If you delete the provision in this bill, you uncouple the specialty network to chronic disease management, and this could have real negative impacts on consumers. Also, I want to speak real quickly about the statements from some of the proponents that they never hear from the specialty pharmacy or the PBM. I can tell you from firsthand knowledge, this is absolutely not true. In my experience during COVID with a child, specialty pharmacy in conjunction with the PBM and home health care staffing have helped my family in so many ways I can't even begin to explain. I don't have enough time to go into this. Finally, in the 340B space, we're concerned this would eliminate any transparency related to the identification of 340B claims and identifying duplicate discounts. Duplicate discounts occur where a 340B eligible provider purchases a drug through a 340B discount program, which is then supplemented when the state requests a duplicated Medicaid rate from a manufacturer for the already discounted 340B drug. This duplicate discounting is supposed to be prohibited under the Federal Public Health Service Act. However, it has proven increasingly difficult to track and mitigate duplicate discounting. We have concerns regarding restrictions that would prevent PBMs and plans from imposing different terms and conditions on 340B pharmacies that are different from other pharmacies, as networking credentialing for the members' benefit help control costs. It's also important just to remember at the very basic level that this is pharmacies trying to protect their discounts and not allow PBMs to account for those discounts, which in turn skews the savings and increases price overall. I am done my time. I'm very sorry. Thank you for the opportunity.
No, no need to apologize. We want to make sure your points are gotten out, and we appreciate your consideration for the clock. Finally, we'll hear from Camille Fesh.
Good afternoon, Madam Chair, Madam Vice Chair, members of the committee. Thank you very much. My name is Camille Fesh, representing PCMA, the National Association of PBMs, or Pharmaceutical Benefit Managers. Most of the points have already been made by the three panelists in front of me, so I'm just going to go very specifically into any willing pharmacy. The reason why we have networks are because the purchaser works with the PBM to come up with the most effective and cost-effective networks for their patients. And when those networks are not allowed to exist, it has some negative drawbacks in terms of the cost of medication and in terms of the consumer's ability to access those medications. First off, right off the bat, some of the preferred networks, the PBMs do need the ability to restrict or have out of network the rare pharmacy that has not handled drugs properly or is engaged in fraud, waste, or abuse. Forcing them to be in any willing pharmacy means you have some increased issues. In addition, it has value-based innovation because preferred pharmacy networks are more likely to participate in value-based care activities, will be held more accountable. There's an emphasis on quality, enhanced level of services. Plan sponsors typically require preferred pharmacies to deliver higher levels of service. And with the exclusivity, pharmacies participating in preferred network can count on predictably higher volume of sales, and increased sales mean a pharmacy can pass the savings on to patients and setting the lower product prices and or lower dispensing fees while still meeting its bottom line. So for these reasons, we oppose the any willing, and it's in a couple of the bills, any willing pharmacy provisions. In addition, all the other points have been hit. We could continue to talk at length about the role of pharmacy benefit managers in the pharmaceutical drug supply chain, but I'll leave it at that. Thank you very much.
Thank you very much. Before we go to questions from the committee, I would like to ask Kimberly Robinson a question about spread pricing so that she has the opportunity to explain a little more to us what was still on her mind.
Thank you so much, Madam Chair. And in my haste in trying to use my 4 minutes, I didn't get to say good afternoon to the members of the committee or the committee chair and vice chair. So thank you for the opportunity. So spread pricing has been a hotly debated topic across the country. And I think what's always been challenging is that one of the most important parties in a spread pricing contract is never at the table at the time, which is our purchasers, the carriers and other employers who are choosing the method under which their contract is being funded with their PBM. Spread pricing has been, become this evil term of art, but what it really reflects is how is the PBM being paid for the services that it is providing for its customer. And I know that there are some who think we're adding no value, but the reality is PBMs add a lot of value to carriers. That's why we exist. It's why, frankly, they've always existed, whether people were aware of it or not. And as our country has become more and more volatile when it comes to drug pricing, PBM's roles have grown because those who are purchasing prescription drugs on behalf of other people needed their leverage and their help more and more. And so when it comes to how we contract with our clients, there are different ways contracts are funded. The two most common are either through what folks call a spread pricing contract or an administrative fee contract. In the healthcare side of the house, you hear us sometimes use the term PMPM, a per member per month fee. It can be done on a per service fee, but PMPM is a very common way to talk about healthcare administrative fees. In the context of spread pricing, if you're not doing this flat administrative fee, that is just simply, we pick a number, we say, this is what we're going to charge you for our services, and they say, well, we're willing to pay that number, and that number just becomes the fee no matter what happens along the way. The way spread pricing works instead is it's almost more like a per prescription fee that's being added in, and it's not to the prescription. It is not connected specifically to the reimbursement. It is instead saying, in this doing this work, here's how we're going to come up with the way that you're going to not have a specific administrative fee and taking another model. It does allow some, for lack of a better description, some value-based consideration in terms of what is the PBM rendering back to that purchaser in terms of value. And so that's sort of how it's baked in. But when we take a step back and we talk about what is the spread, if we were talking about Macy's, right, or generic department store A, and you were to say, I don't understand why if they only paid $6 for this shirt, they're selling it to me for 20. Well, what it is that $14 is their spread. It's the cost that's covering their costs, it's covering their overhead, it's covering any profit that they might make or choose not to make, depending on what they're using that shirt to do in terms of drawing you into the store. But everybody who sells something has a spread to it. And in this case, that's where we're doing this financial exchange, is when it comes to the prescription costs. States that have banned spread, and there are some who have done it in their commercial markets, have only affected their carriers' ultimate costs. And at the end of the day, it's not an amount that then somehow magically transfers into reimbursement to pharmacies, because it was not about the reimbursement to the pharmacy in the first place. And I just think that there's always been some misunderstanding about what it is, and that is simply a model for how the services that are being provided are being paid for. There's a meaning and an assumption about it that's inaccurate. That's sort of the common talking point on the street. We believe at the end of the day, the people who are making these purchasing decisions and agreeing to either have a spread pricing contract or not are very sophisticated, and that if the state is really interested in ensuring that they're not being taken advantage of, it's different if you were to say it can't be the only thing that we offer, but then it allows them to make the evaluations for themselves. They do it anyway. They put it in their RFPs. They request more than one funding mechanism for the services, and then they make the choice that they believe best serves them based on all of the features that come with it. And so we caution the state against banning a methodology that is popular with purchasers who are not at the table asking you to ban it. They know very well, and in this case, it's your carriers. Every carrier in the state knows exactly where you are right now. There's no carrier in the room asking you to ban spread pricing on their behalf. They are, however, here through Mr. Celentano, who represents them, asking you not to. And that's the only entity that you're affecting if you were to move that particular piece of that bill. Thank you.
Thank you. Delegate Kaiser.
Easiest question of the day to Mr. Johansson, Ms. Fesh, Mr. Celentano. I'm new to this committee, as you may have figured out. Do you all have any written information that you can provide on any of this? I'm on video. I'm on audio. I'm not a video. I can see better than I can hear. So anything you can provide?
We have an information packet. The bills basically, some bills had a dozen different items in it. Some bills overlapped. We can certainly send the committee something. We have a packet we'll send you tomorrow morning. Thank you.
Delegate Krebs.
Thank you. I stated my, even though I've been on the committee a long time, Delegate Kaiser, I get confused by this too, and I'm not a shorthand person to try to take notes. And you all obviously just said a lot of opposition, and I appreciate that and respect all of you. However, somewhere you got that opposition and you read from it. I would really appreciate having some of that in writing too, so I could go back and even quote you to ask you a question. So it's really been for years and years a frustration of mine that you guys never provide any written testimony, yet the proponents do, the proponents of the bills, and they somehow take the time to put down their arguments for. And I would like to see in writing your arguments against, so we would have time to digest them, whether you're new to the committee or old to the committee. This is very complicated, but I have a question about the any willing provider. I think Matt said that any independent pharmacy or chain can join any network anytime and enjoy the benefits of the network. And I think, Mr. Johansson, you compared it to physicians joining networks and negotiating prices. So I'm trying to figure out, and I guess I should ask the question to one of the providers, that the pharmacies. So Mr. Hose, can you just join one of these people?
Wait, Mr. Hose was on a previous panel. This is the time for questions for this panel.
I'm sorry. So I'll ask, if I was to ask the independent pharmacists if they were able to join one of these PBM networks and have the same pricing, the same benefits, the same everything, would they be able to do that?
Can I answer the question, and I'll explain how it typically works?
Sure, thank you.
Large chains typically negotiate directly with PBMs because they're large enough to have those conversations. They're typically negotiating with a PBM across the whole country, right? Regardless of which state they're dealing with. Some independent pharmacies on their own can pick up the phone and negotiate with a PBM. That's typically rare. What happens for the independent pharmacies is they belong to organizations called PSAOs, Pharmacy Services Administrative Organizations, and those PSAOs negotiate on behalf of groups of independent pharmacies. I think Brian mentioned Epic has 135 pharmacies, and they can negotiate as Epic, or they could even join a different PSAO and negotiate together. So what typically happens is they aren't guaranteed to be the same, to receive the same reimbursement as someone else who's separately negotiating, but the ASO, the PSAO they're working with, probably will ensure that they all have the same reimbursement. But no, I mean, if someone doesn't like the reimbursement that's being offered or is contracted with, they don't have to take the contract. And if they want to be reimbursed more than what the PBM believes they should, the PBM won't let them in. It is truly a negotiation.
Can I have one follow-up, Madam Chair?
Sure.
I think it was mentioned by a couple of you a couple of times that PBMs add value to carriers, and I get that. I believe that's absolutely true. I think us on the committee, we want to provide value to our consumers, to the constituents. And there was some testimony earlier from a doctor and also from one of the bills, doctor, from a patient of some of the impersonal non-care that they received from the PBM, of not having the things you say that are offered. They were saying that wasn't realistic to them. That was not reality. So how do we give that consumer a choice of whether to go with the big guy that doesn't necessarily give you the care, or the person down the street who you think you have that relationship with? How do we make sure that our consumers have that type of choice, that they can choose, so that they can pick what type of value they want to get from, values on the eyes of the beholder. It's not just the drug all the time. Sometimes it's about how to administer the drug, or having somebody pick up the phone and answer a question. So how do we calculate into our decision making?
Delegate Krebs, if an individual who's a member of a health plan wants to go to a particular pharmacy, it's a simple question of whether or not they're in the network. And we just talked about not everybody's going to be in the network, but many are. For example, the state employees health plan probably has more than 90% of all the state's pharmacies in the network with that PBM. Okay, so the vast majority are. Secondly, I think with respect to House Bill 1015, which was Delegate Young's bill, where they talked about the oncology practice and being able to work with a patient and then also being able to provide them their medication, it was interesting. It was described from a consumer perspective as choice, but it was also described as a bill that, well, let's prevent PBM steering. I thought the most interesting thing about it was you have the practitioner who actually prescribes the medication, who's concerned that the PBM wants to send them to a specialty pharmacy, but this particular group of practitioners basically wants to prescribe the medication and then dispense it. And I think Delegate Cullison asked the question, well, can they? If they're in the negotiated network, they probably can. I think the bigger question is, are they willing to sign a contract and perhaps be reimbursed at a number that they're not willing to do? Though they have that option of becoming a specialty pharmacy and then being able to provide that service. I think the question, and that particular bill was in this committee 2 or 3 times over the last couple of years, and it failed every time. It was labeled something differently. It totally got turned on its head as, quote, an anti-steering bill, but basically it's an in-office dispensing bill, and they want to be in the specialty network without necessarily agreeing to all the specialty networking contract requirements, including price.
Thank you, Mr. Johannes. I just think sometimes when you give an answer like 90% of the pharmacists are in the network, it doesn't mean they're all being reimbursed the same, and then they can't stay in business under the reimbursement policies. But we can talk about it more in subcommittee.
Thank you very much. Delegate Cullison.
Thank you, Madam Chair. I think this question is for Kim Robinson. I heard, I think, from at least 2 proponents that there's a study that says that states that have regulated PBMs have actually saved money. Can you speak to us about that study?
Sure. I think it's an interesting assertion that just because the state has regulated PBMs, that any decrease and you're having a slower increase of healthcare costs, that is the single thing that it must be attributable to. I think if any place in the General Assembly, it is this committee who knows how multifaceted state regulation of healthcare costs are, all of the various factors that go into shaping what the healthcare cost experience is in any particular state. And the fact that there's never a single linear option for what is causing the savings on healthcare spend in a state. And so while I think that we all understand correlation, we also understand that there's a difference between causation. And so while it might be correlated that states who have also regulated PBMs might have found that their healthcare costs are rising slower than maybe another state, I think there's a huge jump between that identification of fact and deciding that it must be the single thing that is the thing that is making the difference without looking at any other thing happening in that state. And so I would just caution the committee to just not take that at face value to say, because you regulated PBMs, it is magically saving costs. When we look at the things contained in these bills, there are things that are absolutely proven to increase costs. The FCC says that, the FCTC says that any willing provider laws of any kind for any kind of providers increases costs, and did a letter specifically to pharmacy. We know that Medicaid in Maryland can say for itself that they know that they made a choice to increase their own costs to move to a spread pricing contract. So there's definitely things that have their own record of fact where cost is concerned. And I just wanted to make sure to draw attention to the fact that that report, while accurate, likely accurate in terms of the correlation, is not the same as causation.
Thank you, Madam Chair.
One more question from Delegate Johnson.
Thank you, Madam Chairman. And this question's for Mike. Mike, you mentioned a little while ago that the pharmacies are getting paid the amounts they agreed upon. But at a pharmacy, when you pull up a point of sale, when you go to sell a drug, it tells how much you paid for the drug. It tells how much you're going to receive for the drug. So you sell the drug. But then you get a letter from the PBMs, could be 2 to 6 weeks later, that says, no, you're not going to get that amount. We're taking our piece off. So that's where they get into skimming the fees. And I think that that is what Delegate Kipke was talking about. So the pharmacies are not getting their full amount that they were promised they would be paid. Instead, they're charged fees on the back end that a lot of times results in a loss on that drug. And that's happening. I think we heard other folks testify anywhere up to 50% of the time. So can you tell us about that?
Yeah, and thank you, Delegate Johnson. And honestly, we've had conversations about that in the past. I think one of the provisions of the existing law limits some of the retroactive adjustments. But when I say they are getting paid what they have agreed to, the PBM still is only pursuing those adjustments if they're contained in the contract in some way. It may, in fact, be that they're allowed to make adjustments after that time of dispensing. But in my view, and I think, unless someone has complaints to the MIA to show otherwise, they are still only making those adjustments if they're permitted under the contract, which has been, entered into by the PSAO on behalf of the pharmacy. I do believe, and you're right, that current law for what has been regulated so far has prohibited some of those adjustments. And I think the question would be, if you were to pass that same prohibition to all the currently ERISA exempt plans, it's going to cost the plan purchasers the money. The PBM is not going to lose money if you pass that law. Our reimbursement is going to be the same.
Well, I think it's not about PBMs losing money. I think it's about pharmacies getting the full amount of the reimbursement for the drugs they sell. But thank you for your answer. Thank you, Madam Chairman.
Absolutely. I see no more hands up, so that concludes the hearings on House Bill 755, 1014, 1015, and 1274. Thank you to everyone for your cooperation with this hearing today. We will be taking our committee break now. It is 3:31, so we will be back at 3:46, and then we will have 3 more bills, 973, 1007, and 610. Thanks so much.
That whole last 20 minutes, I was like, shut up, people.
Delegate Kelly, you may want to mute.
Hello, everybody. It is time for us to reconvene. So let's make sure everybody's getting settled and getting their cameras turned back on. I am presenting the first bill, so we will just confirm that my panel is present, and they are, because they are excellent team players. Thank you all so much. So we can go ahead and get started. We're going to be hearing House Bill 973, Pharmacy Services Administrative Organizations and Pharmacy Benefit Managers Contracts. So we heard a little bit about PSAOs in the last conversation. This is a really simple bill. It's a technical fix for some reporting issues that were created by a bill we passed in 2020. So I had this bill a couple of years ago. It established some requirements. We needed some technical fixes. The MIA has agreed that we need them. I will let the panel talk about the specifics, but I believe that everybody is on board and in support of this legislation and agrees that it is needed. With that, I will hand it off to Camille Fesh.
Thank you very much, Madam Chair, Madam Vice Chair, members of the committee. For the record, my name is Camille Fesh, and I'm here representing PCMA, Pharmaceutical Care Management Association, the National Association of PBMs. We are here in favor of this bill. We worked very closely on this bill a couple of years ago, and just speak very generally to why the PSAO law exists. The pharmaceutical drug supply chain, as we have discussed today, is very complicated and has many different players. It is important from a policy perspective that those links in the chain are visible to the Maryland Insurance Administration and also visible to the legislature, so that you have all the information you need and to make sure that the entities involved in the drug supply chain are well regulated. So this PSAO law helped stop some of the gaps in visibility. We have talked to the MIA, we support all their changes, and of course we always support the MIA's ability to make a law more workable and more functional with technical changes. And PSAOs, what they are is they are administrative organizations, and they contract with independent pharmacies, and then on behalf of the independent pharmacies, they contract with PBMs and potentially wholesalers. Now, some of these PSAOs, Epic is one of them, but some of the other ones like AmerisourceBergen, Cardinal Health, and McKesson are some of the largest companies in the United States. And a lot of them also are wholesalers as well. So it is a complicated system. It's a complicated series of relationships. And we are thrilled to be able to support more visibility and more transparency for both the Maryland Insurance Administration and for the Maryland Legislature. Thank you very much.
Thank you very much. Next, let's hear from Mike Johansson.
Thank you, Madam Chair. Again, Mike Johansson on behalf of PCMA in support of the bill. Thank you. I just wanted to take, because since we had kind of a compressed time, just a few seconds on this concept of vertical consolidation, meaning it was suggested, well, you have PBMs that own pharmacies, and now they own insurance companies, and insurance companies own pharmacies. You know, this is an example when you look at the relationship between the contracted entities called pharmacies and PSAOs who work on their behalf to negotiate reimbursement rates with PBMs. The AmerisourceBergen, Cardinal Health, McKesson, wholesale distributors, there's the ones who are selling drugs in the prescription supply chain to the pharmacies and then negotiating reimbursement rates for ingredient costs with the PBMs. So when we look at these complex issues, we tend to think as the retail independent pharmacies as the little guys, and individually they perhaps are. But when you look at these large behemoth organizations, McKesson's number 7 on the Fortune 1000, AmerisourceBergen number 8 on the Fortune 1000, Cardinal Health number 14 on the Fortune 1000. They're not only large enough entities to be sophisticated to negotiate these agreements on behalf of independent pharmacies, which they do. And when an independent pharmacy says we're not being paid enough, they're being paid what they agreed to in their contract. No one can suggest it's wrong, but it does make it more significant. They're directly helping to determine the price for which the drug product that they distribute is reimbursed for. So someone said it's complex. We completely agree. We just want you to keep focused on the entire stream, not just the PBM component. Thank you.
Okay, thank you. Let's hear next from Scott Pace.
Thank you, Madam Chair and committee members. My name is Scott Pace, and I'm actually a pharmacist and a pharmacy owner in Arkansas, and I do some consulting for the Healthcare Distribution Alliance, which is the trade association that represents the pharmaceutical wholesalers. In this particular case, the pharmaceutical wholesalers have partnered with PSAOs that are non-owned by wholesalers, as well as the PSAOs that are owned by wholesalers, to come together to try to fix the technical issue that Delegate Kelly has so graciously worked on. In this particular case, the 2020 bill put some licensure requirements on PSAOs and some disclosure of contract requirements on PSAOs to the MIA. And the way that those contracts were required to be disclosed required the PSAOs to basically disclose the contracts that were originated by the PBMs, making it very difficult to comply with the intent of that law. This technical cleanup that Delegate Kelly has put forward, and we're very appreciative for that, changes how the contracts get to the MIA, but the net result is the same. Those contracts will still be there so that the MIA can have appropriate insight into those contracts with the PSAOs and the PBMs. So we appreciate that very much. I will say that the pharmacies, independent pharmacies like myself, will still be able to retain access to contracts, so they can still request those from the PSAOs. That's in current statute. This clarifies it a little bit to make sure that they can get it either electronically or written, and it's a good change, and will hopefully help to keep some of the PSAOs who don't have that massive antitrust exemption to be able to negotiate, like it's kind of being portrayed by PCMA, will help keep them able to operate in Maryland after we've already lost one in the last month. So thank you, Delegate Kelly. Appreciate it.
So much. Let's hear from Brian Hose.
Thank you. We're certainly in support of this legislation. Epic has worked to help with the regulations, has worked to comply with the 2020 bill as best we can. We did have one PSAO, as Scott alluded to, that decided that they could not comply with the regulations as they were set forth prior to this bill, and dropped out of the state of Maryland. And just so you folks understand what that means, that left a pharmacy, or 19 pharmacies in this case, with 30 days notice to recontract with all of the PBM entities. And I know we talk about there being 3 big ones that control 80%. There's lots of other ones as well. And that was a pretty difficult situation to put those 19 pharmacies in because of that 2020 legislation. So we are thankful that, from our understanding, not very many of them are just going to close their doors. But these laws do have consequences, and certainly we're glad that we're going to be able to help make this one a little bit more palatable for some of the smaller groups that don't have the resources of, say, a McKesson or an AmerisourceBergen or a Cardinal. And this was a fairly decent sized one. But we certainly support this, and are thankful that Delegate Kelly was willing to revisit with us. Thank you.
Thank you so much. We have a question from Delegate Cullison.
Thank you, Madam Chair. I'm first going to take the liberty to say I believe this is probably the first time that we have seen independent pharmacists and PCMA sitting at the table together, even if it is a virtual table. I just want, I do have a question, which is to clarify, again, this drug chain that Camille Fesh spoke to, I think, very clearly. There are 2 levels of contracts. One level of contract is between insurance carriers, sometimes known as purchasers, and PBMs, and then between PBMs and a PSAO that represents a group of, most often, independent pharmacies. And that this bill is speaking to that contract, the one between the PBMs and the PSAO. And the PSAO is the one negotiating with the PBMs. Am I right? Am I correct in capturing the chain that way? So, and I think anyone who feels like they can answer it I can. Just
Madam
throw it
Chair,
out.
I think the law that was passed in 2020 and is being clarified, for the most part, talks about the contract, the next level contract, which is between the PSAO and the pharmacists.
This law is doing that, correct?
Right? Because
Yes.
it required MIA to be aware of through registration or licensure of PSAOs who not only contract with PBMs directly, but have arrangements with pharmacies. So
Right.
it goes that direction as much as we, the PBM, have to provide certain information to the PSAO. But this bill was specifically introduced before the pharmacy PSAO connection.
Right. And that's what I wanted to clarify, because I think sometimes we get confused over who's contracting with whom in this particular chain. So thank you I just wanted to make sure the committee understood that. So thank you.
Excellent. Any more questions for this panel? There's no panel of opposition signed up on this one. I see no more questions from the committee, so that concludes the hearing on House Bill 973. Next, we will move on back to Delegate Kipke, House Bill 1007, Maryland Medical Assistance Program and Managed Care Organizations that use pharmacy benefit managers reimbursement requirements. Delegate Kipke.
Thank you, Madam Chairman and members. No shortage of controversy in these bills today. This one is no exception. This bill would change the way in Medicaid pharmacy is reimbursed for their services and the prices that Medicaid pays for the actual therapy or medicine. Basically, this bill would affix Maryland's reimbursement rate for the medicine to a national standard that's used in Medicare called NADAC, and it would establish a fee that would be like a fixed fee that would be paid to the pharmacy for dispensing. The fee isn't an arbitrary number that was picked out of the sky. It's the result of a study that was done by the state of Maryland that assessed how much it costs in terms of overhead of a pharmacy and a reasonable reimbursement for their professional services, how much that is per prescription. So the pharmacists believe that this is a fair reimbursement for their work. They also believe that it would also provide cost savings to the state of Maryland, which isn't reflected in the fiscal note, but we've sent a very extensive set of questions, basically challenging Medicaid to look at what other states have done when they've moved to this model. Other states have shown cost reductions. That's not illustrated in the fiscal note. And some believe that the Medicaid is missing the boat on this. So we pushed back a little bit. They may be right, I don't know, but we pushed back on it with some questions that I'll share with the subcommittee, and hopefully I'll have those answers soon. So with that, I thank you for your time.
Excellent. Thank you, Delegate Kipke. Let's hear from Jim Doyle. Jim, are you working on unmuting?
Sorry, I'll get the hang of that one of these days. Jim Doyle on behalf of the Independent Pharmacies of Maryland. And we agree and support this bill. The fact is that for a long time, independent pharmacies have been taking significant losses, particularly for filling Medicaid prescriptions. I've heard that they basically take losses on almost all of them. They get dispensing fees in the order of 35 cents, 50 cents per prescription, which is nowhere near the actual cost of a professional dispensing fee for that prescription. I've read the fiscal note. I know this bill has been in before, and I've read the fiscal note that just came out the other day on this bill. which is substantial. The problem that I suppose I have with the fiscal analysis is that I think there needs to be some more work done on that in terms of what the true cost of this program would be. I suspect this program could be implemented in a way in which it was much more economical to the state. So, for example, spread pricing issues are not taken into account in this analysis from what I've seen. In addition, the state has the right to include and as well as exclude certain types of pharmacy operations from a bill such as this type. Every pharmacy, as we know, we've listened today, all these pharmacies are not the same. They all have different revenue streams and different sources of income, and it's quite a difference between the way they operate. Those things can be taken into account, and I think the fiscal note could use more analysis and could be much more favorable and beneficial to passage of this kind of legislation.
Great, thank you so much. Let's hear next from Brian Hose.
Hi, this is Brian again. It's good to be able to talk about this bill. This is something that we've talked about over the last several years. We know that ever since Medicaid fee-for-service switched to an NIDAC Plus model, they went to a fair dispensing fee based on two studies now that they've done. The initial one when they switched the program over, and then another one that they did years later. The interesting thing is that the dispensing fee remained relatively constant. We were close to $10.50 the first time. I think we're $10.60 now. The dispensing fee is what it costs a pharmacy to have staff here, to have the lights on, to print your label, to package the product, to provide counseling, to do the drug utilization review, to do everything that's required to get that prescription out. Certainly 10 cents or 35 cents is pathetic for a professional dispensing fee. And that's what we see right now from the Medicaid MCOs that are allowed to let the PBMs contract these rates, pretty much take it or leave it. I know we say negotiation and Mike throws that word around a lot, but even Epic that has close to 1,200 stores that it negotiates for, these are not negotiated contracts like you think they would be, a negotiation back and forth. These are pretty much take it or leave it contracts. We certainly wouldn't take a 35-cent professional dispensing fee when we know it costs us close to $10.60 if they weren't that way. NADAC, for those of you who are new to the committee, is a surveyed drug cost. So Myers and Salfer, a national accounting firm, does a survey of all pharmacies on a rolling basis. It's a continual survey to be used within the Medicaid space. And it surveys the costs of these medications to the pharmacy. So that average is very close to a pharmacy's actual cost. And that dispensing fee of $10.60 is very close to a pharmacy's actual cost. So when we talk about this bill and we see a huge fiscal note, we know that it's not being calculated properly. The state should save money if they pay very close to the pharmacy's cost on the drug and very close to the pharmacy's cost to dispense it. The state is really not spending any money they don't have to, specifically not giving money to the PBM.
Very much. Do we have questions for the proponents on this bill? Waiting, I see no hands up. So let's move to the panel of opposition. First, we have Mike Johansson.
I believe Mr. Johansson
not here. Okay.
Yeah.
Let's hear from Camille Fesh first, and then we can hear from Jennifer Bremen, and then maybe Mr. Johansson will be back. Go ahead, Camille.
Thank you very much. Thank you very much, Madam Chair, Madam Vice Chair, members of the committee. Again, for the record, my name is Camille Fesh, here representing PCMA, Pharmaceutical Care Management Association, the National Association of PBMs. We are here on the opposite side of the table where we normally are. We respectfully oppose this bill. To state, this isn't putting more money or taking money away from the PBMs. This is really putting money on the backs of the consumers and on the backs of the state money and the taxpayers. As you can see from the fiscal note, even though the MCO's estimated total ingredient costs are estimated to decline by $12.9 million. The expenditures for dispensing fees are estimated to increase by $109 million. And you can see that if you look at fiscal year 2023 and beyond in the fiscal note. So the fiscal note to us is alarming, and that's going to raise the cost of premiums. It also doesn't provide for any additional new or enhanced services. This is for the current level of services that pharmacists do provide. In addition, a lot of this money, we estimate about 2/3 of it will go towards large chains. It's not going to go to the independent pharmacies or the smaller entities in the state. It's going to go to the larger chains. And if this is extended, if you look at House Bill 1009, which we know was withdrawn, that fiscal note for the state employees plan does have an estimated cost of $40 million. So you can see that these are significant amounts of money that are being put forth. That this is money that, as we know, state budgets are limited, money that's not being used elsewhere. So with that, we respectfully decline. Thank you very much.
So much. Let's hear next from Jennifer Bremen.
Good afternoon. Thank you, Madam Chair, Madam Vice Chair, distinguished members of the committee. Thanks for the opportunity to speak with you today. My name is Jennifer Bremen. I come before you today representing the Maryland Managed Care Organization Association. MMCOA represents the 9 managed care organizations that serve over 1.5 million Marylanders enrolled in the Health Choice program. The MCOs respectfully oppose House Bill 1007. As you will read in our submitted written testimony, and as we have in prior sessions, we come to you with concerns about this bill's provisions, and we offer an alternative to implementing the measures proposed by the bill sponsor. There have been many changes implemented with the goal of reducing Medicaid's pharmaceutical spend, including the elimination of the spread pricing model and the implementation of a pharmacy appeals and grievance process. The MCOs respectfully recommend that the impact of these significant changes be examined and considered by this body before more sweeping changes were to be made. These cost-focused pharmacy initiatives are in the early stages of their implementation, just having been implemented in January of 2021. And we feel as though their impact must be evaluated and understood before more measures, including the ones included in House Bill 1007, are adopted, perhaps to the detriment of the program's quality and service to our members. For these reasons, we respectfully urge an unfavorable report on 1007. Thank you.
Thank you so much. Is Mr. Johansson back yet? Mike Johansson, are you here? Don't think he's back yet. Nope. Okay, so let's go to questions. Delegate Cullison. Delegate Cullison, you're on mute.
Sorry. I think I would know better by now. But this is for Ms. Bremen, I think. And I'm sorry, I was writing something down, so I didn't process the second part. You said your alternative is to study the impact of the prohibition of spread pricing in the MCOs. What was the second part?
The implementation of an appeals and grievance process that went into effect at the same time as the prohibition and spread pricing was implemented in the MCO annual contracts with the state.
Okay. May I follow up, Madam Chair?
Sure, yeah.
Do you have any information, and not specific data, and if you don't have it, maybe you can get us in terms of the numbers, the amounts of appeals and grievances that we've had since that was passed, I think, in 2020?
Sure, I can. I would be able to try and get that, even though it would be across all 9 MCOs, collecting that information. But let me see if that is available, or if that's something that the department might be able to help us with. But I can get back to you on that for sure.
Okay. Thank you. I appreciate it. Thanks.
Any more questions for this panel? Seeing no questions, that concludes the hearing on House Bill 1007. And we will move on to the last bill of the day, which is House Bill 610, Delegate Ruth. Delegate Ruth, welcome to the committee. I'll remind you of our rules. You will have 5 minutes to present the bill, and you can, if you want to use all 5 minutes yourself, that's fine. If not, you can defer to save some of that time for one of your panelists. Normally we have 5 proponents. This time we had a little snafu, so we're going to hear from 6 proponents. So I want the committee to be aware of that. And with that, I turn it over to Delegate Ruth. Welcome.
Thank you, Madam Chair. For the record, Delegate Sheila Ruth, I'm presenting House Bill 610. This bill creates a commission to study and develop a plan for statewide single-payer universal health care. You can think of it as similar to the Kirwan Commission, but with a focus on health care. The General Assembly would then be able to decide whether to introduce and move forward with the plan after the commission's work. Despite our best efforts to ensure every Marylander coverage, the patchwork system of insurers from Medicare and Medicaid to myriad private companies and plans still leaves too many uninsured or underinsured, and even many of those who have health insurance can't afford to go to the doctor due to high deductibles and out-of-pocket costs. As this committee knows, when people avoid getting treatment, they risk getting sicker, leading to worse outcomes, including loss of income, loss of a job, and even premature and avoidable death. This goal is to ensure that all Marylanders, regardless of income, assets, health status, citizenship, or immigration status, or availability of other healthcare coverage, will have access to quality, affordable healthcare. There's been a lot of work done in other states, including New York, Maine, and Washington, that this commission could build on, so they're not starting from the square one. I know that this committee has seen this bill in past years. I've made some changes to it this year. Of particular note, I want to make sure to call out that the bill is no longer burdened with the large fiscal note that it's had in past years. We were able to eliminate that with changes to the bill and discussions with MDH. Just the fiscal note just includes a note that any costs would depend on consultants that the commission decided to hire. I also added equity provisions that the commission should incorporate healthcare equity, reduce healthcare disparities, and increase healthcare access, particularly in urban and rural settings with limited access, ensure that the plan covers reproductive care, and a plan for transitioning workers displaced by changes to the healthcare system. I'll note that the bill is supported by the Latino caucus. I'm going to turn over the rest of my time to Christy Fogel. And with that, I ask for a favorable report for HB 610. Thank you.
Thank you very much. So Christy Fogel, you can have the 2 minutes and 39 seconds left, as well as your own 2 minutes. Welcome, Christy.
Thank you very much. Distinguished members of the committee, thank you for the opportunity to speak with you today regarding this critical piece of legislation. My name is Christy Fogel, and I come to you today as an emergency trained physician assistant, a health justice activist, and founder of the Maryland Progressive Healthcare Coalition. I'm a resident of Baltimore County, and I have been practicing medicine in and around the Baltimore region for the past 9 years. As a healthcare provider, I speak today on behalf of my patients who suffer within a for-profit, insurance-driven healthcare system, which consistently fails to meet and address their medical needs. The uninsured patients who I've cared for in the emergency department make up but a small fraction of the over 30 million Americans who continue to be without health coverage, even with the expansions provided by the ACA. These patients make too much to qualify for state Medicaid, but still are unable to afford the high premiums and high deductibles that are offered by the private insurers, leaving them falling through the cracks of a broken healthcare system. These patients often avoid their symptoms and come to the emergency department once their symptoms have progressed to life-threatening illnesses. As you can imagine, this has both moral and fiscal implications. As an ED provider, I saw patients like this every single day for years, patients who were forced to avoid their treatment until it became unmanageable because they can't afford it. Patients who ration their high-cost, life-saving medication until they run out of their medication. I've seen diabetic patients who come in with blood sugars in the thousands because they were forced to ration their insulin, which can ultimately lead to diabetic ketoacidosis, which is a diabetic emergency that can quickly lead to death. Today, I also speak on behalf of an equally desperate group of patients, and those are the patients who are insured by the private for-profit health insurance companies. From these patients who actually have private health insurance and are considered covered by providers in the ED, we frequently hear, how much is this going to cost? My insurance won't cover this. I can't afford the bill. I've had patients get up and walk out against medical advice when I attempt to admit them to the hospital or tell them they need emergency surgery. One patient who came in for chest pain begged me not to order too many tests because he said, quote, "I can't afford it. My insurance won't cover it." I had a patient with insurance who had appendicitis. He left the hospital because he said his deductible was too high and he'd rather, quote unquote, take his chances. This is not what I went to school for. This is both frustrating and heartbreaking to witness as a healthcare provider who took an oath to care for my patients to the best of my clinical ability. But the problem is this: I don't care who you are or where you trained. It is impossible to practice to the best of your ability in a for-profit, multi-payer, insurance-driven healthcare system. As an ED provider, I could easily receive 10 or more calls a day from pharmacies asking for medication changes due to the insurance company denials that they receive. Most times, these were antibiotics and other essential medications that I'm being asked to switch to less expensive and also less effective medications. Providers like myself waste significant amounts of time on the phone when we could be seeing patients that are currently sitting in the emergency department in need of our immediate attention. Prior to the COVID-19 pandemic, there were 80 million people, or nearly half of all adults under age 65, who were uninsured or underinsured. Nearly 500,000 Americans went into medical bankruptcy each year. In Maryland, with the ACA fully expanded, that equates to 6% still left uninsured. And fast forward to 2022, over 27 million more individuals nationwide have lost their employer-sponsored health insurance. Maryland patients need the General Assembly to step forward to ensure that they stop falling through the cracks of the system that has been complicated overly by multi-payer administrative costs and an emphasis on profit over patient care. This bill, HB 610, will take the necessary steps towards creating a Kerwin-like commission for healthcare that would consider plans and analyses done in other states on how to ensure Marylanders will have equal access to healthcare, include a benefit package which covers primary and preventative care, and increase healthcare access in underserved and urban areas. Marylanders deserve a universal system that focuses on their care without middleman profiteering by the insurance industry. This committee must address the growing crisis that affects Maryland patients and is only worsened by the COVID-19 pandemic. This bill, if enacted, will take an important step towards providing the high quality and equitable universal coverage that Maryland patients desperately need. On behalf of my patients in our community, I ask that you pass this measure with a favorable recommendation because Marylanders deserve the basic human right of health care. Thank you.
Thank you so much. Let's hear next from John King.
Thank you, Madam Chair, members of the committee, and thank you to Delegate Ruth for her leadership on this bill and sponsoring this critical legislation. My name is John King. I'm here today as a teacher, a former principal, as U.S. Secretary of Education for President Obama, to express my strong support for HB 610, legislation that is an important step toward ensuring that we finally begin to treat healthcare as a human right here in Maryland. As a lifelong educator, you learn very quickly the importance of seeing the whole child and the impact that everything from housing insecurity to food insecurity to lack of access to healthcare can have on children's development and education. If a student or their family does not have sufficient healthcare, they are likely to suffer in the classroom. While Maryland is fortunate to have a well-regarded healthcare system, it's unacceptable that the richest state in the richest country in the world would have over 350,000 people without health insurance. It's unacceptable that we would allow massive disparities to exist in our healthcare system because of income and race. It's unacceptable that we would allow huge disparities in access to doctors and specialists. We can and we must ensure every Marylander has health care, regardless of their immigration status, economic status, racial identity, disability status, religious identity, LGBTQ status, region of the state, or any other factor. That's why passing HB 610 is so critical. While it's long overdue to pass Medicare for all at the national level, it's vital that we do everything we can to ensure everyone in Maryland has health care. The commission this legislation will create will allow the state to develop an actionable plan for universal health care for all Marylanders. As we've seen with the COVID-19 pandemic, our state government must lead on healthcare equity and access. For these reasons, I urge a favorable report on HB 610.
Thank you so much. Great use of our timer. We appreciate it. Next, we will hear from Mayor Selena Benitez. I believe Mayor Benitez is here. She is muted. Mayor Benitez, you need to unmute. I am having trouble finding her face on the camera, but I hear she is here and still unmute. Why don't we move to the next panelist and we'll give the mayor a moment to figure out her tech issues. Let's move on to Connie Serrano.
Thank you, Madam Chair, members of the committee. My name is Connie Serrano. I am the Healthcare Research and Policy Analyst at CASA, Maryland's largest immigrants' rights organization. On behalf of our membership of over 12,000 Black and Brown immigrants and working families, CASA asked the committee for a favorable report on HB 610. This bill will establish a commission that will develop a plan for Maryland to establish a universal health care program through a single-payer system that covers all Marylanders. This bill puts us on a path to true health care for all people in our state. In Maryland, there are currently over 300,000 people who are uninsured with health disparities impacting particularly communities of color. The COVID-19 pandemic provided renewed proof that while Maryland has made great strides in providing care for all its residents, there are a significant number of communities being left behind. The system currently does not serve everyone. Healthcare coverage through employment leaves out small businesses and companies who do not or are not able to offer their employees healthcare benefits. This also leaves individuals at risk of losing coverage that is linked to their employment should their employment status change. There are 275,000 undocumented immigrants who continue to be ineligible for federal programs. This often leads families into emergency rooms as they are forced to face life or death situations due to their exclusion of programs such as the Affordable Care Act, Medicaid, Medicare, and CHIP. The current system also allows health insurance companies to restrict expensive medication, tests, procedures, and other services by declining coverage through private plans. Regardless of the coverage Marylanders are or are not receiving, the primary reason that prevents Marylanders from accessing healthcare service is the incredibly high cost. Marylanders with below average incomes being most at risk as getting basic care has become unaffordable. Committee members, healthcare is a human right. It is critical that we begin to move towards a system that is inclusive of everyone. This bill will be the first step towards correcting healthcare disparities and create a framework for a system that serves all Maryland residents. For these reasons and so many more, we strongly recommend a favorable report for HB 610. Thank you.
Thank you so much. Let's hear next from Michelle Gregory.
Thank you very much to the members. I appreciate your time and energy in this matter. As a resident of Wycomico County and a Salisbury City Council member, I'm expressing my support for this bill, which would establish a commission on universal health care. This commission would develop a plan for a state universal health care program that would provide health benefits to all Maryland residents through a single payer system. My family has seen more than our fair share of medical emergencies, and we've been fortunate enough that my husband's employer provided a means to purchase health insurance. In recent years, however, my husband's health has taken some big hits, and that will be with him for the rest of his life. These debilitating health issues have been a struggle, as is the knowledge is that when he stopped working because of his disabilities, we would lose our health care coverage for the entire family, each of whom has their own disabilities and relies on frequent doctor or specialist visits and medications. I represent a district filled with people facing these same issues. Many jobs on the lower shore do not even offer health insurance. And when they do, the coverage costs are out of reach for most. Between plan premiums that run in hundreds of dollars to deductibles, some as much as $10,000 per person, it's still far out of reach for too many. In addition to helping average Maryland families, this bill would help municipalities cut costs. Salisbury offers employees health coverage, spending $3.7 million per year covering both current and retired employees. While Worcester County, our neighboring county, budgets nearly 10 times that amount. If the state were to create a universal health coverage plan, that burden would be lifted from our city and many other municipalities and counties around the state. As we continue to deal with the ramifications of the COVID-19 pandemic, Marylanders need you now more than ever to take the first step in becoming a national leader in healthcare. I urge a favorable report with no weakening amendments on HB 610.
So much. I believe that Jared Shablin is not here. So I just want to confirm that. And I see, so Mayor Benitez, I think her video is not on. I'm going to give her one more call just to make sure she's not able to join us. I think she is probably pulled aside doing some important mayor work. So with you are welcome. Well, let's hear your testimony then. Thank you so much for joining us.
My apology. I don't even know what that looks in the screen. So I'll tell you what my testimony is. So thank you for having me. Selena Benitez, the city of Mount Rainier. As the mayor of the city of Mount Rainier, I'm writing to express my support for HB 610, sponsored by Delegate Ruth, which will establish a commission of universal health care. The commission will develop a plan for a state universal healthcare program that will provide health benefits to Maryland residents through a single payer system. Last year, Prince George's County Council passed the first resolution in Maryland in support of the Federal Improved Medicare Act for All of 2021, which was driven by the disproportionate impact of COVID-19 crisis in our county. Residents and highlighted the failure of the employment-based health insurance system, the limitations of Affordable Care Act, and the plea for uninsured and underinsured residents. Under the Improved Medicare for All, every person leaving the U.S. will receive comprehensive health care, including primary specialist care, hospitalization, dental, vision coverage, prescription drugs, long-term care, and much more, all without paying extra prices of insurance. The pandemic has taught us that we cannot continue to attach employment to healthcare. And if we were previously before one paycheck away from going bankrupt, if we had to deal with a medical emergency, the pandemic showed us like those rates were even bigger, as some of the people that were in well positions and had plenty of savings currently are still facing bankruptcy and financial struggles. So I will say to you, creating a Kerwin-like commission for healthcare is important, is something that we need, and we need to make sure we're taking care of our residents equally, regardless of who they are. So this commission is needed, and I ask for a favorable support for HB 610.
Thank you so very much. That is the final panelist of proponents. We do have one unfavorable sign up, but let me go to questions from the committee for the proponents of this legislation. Are there any questions? I see a hand from Delegate Lewis Young. Go ahead, Delegate Lewis Young.
Thank you, Madam Chair. While this concept is very appealing to many of us, the challenge has always been the devil in the details. And whether or not it's feasible at a state level, either from a financial perspective or an operational perspective. So I understand this bill sets up a commission, but where would you look in the United States for best practices as a model at the state level?
Thank you so much for that question, Delegate. And so yes, it's true that no state has yet enacted it, but there's been a lot of work done in various other states on this. Some states have come close. New York has passed the New York Health Act 4 times through the Assembly. It hasn't yet got through the Senate. I think that it has more co-sponsors in the Senate this year, so they're hoping that it has a chance. But there was a 2018 RAND Corporation assessment of the plan, which estimated that greater healthcare coverage could be achieved at equivalent or slightly lower overall cost, and that 90% of households would pay less. Maine actually last year in 2021 passed the Maine Healthcare Act, and so they actually passed a single payer system. However, theirs does not go into effect unless the federal government passes a law that would enable waivers specifically for single payer. That's not that far-fetched because Representative Ro Khanna actually has a bill that would create such waivers. So if that bill were to actually pass, then Maine's healthcare system would begin to be implemented using those waivers. There was actually an analysis in December 2019 from the Maine Center for Economic Policy, which showed cost savings for most individuals and employers, including state, local, and municipal governments. And we heard from several municipal leaders today about what it would mean for their cities. There is a grassroots effort in Washington State called Whole Washington. Well, excuse my accent. That is, attempting to put it on the ballot. This is a very large effort. They have actually paid for an economic analysis, which estimates that the plan would generate $9 billion in annual savings. And all of these plans have looked at not only the funding, but how you would incorporate, because one of the biggest complexities is how to incorporate like all the federal programs that come into the state. So waivers obviously are the best way to do that. And we hope that the federal government would allow those waivers. We should be able to create Affordable Care Act waivers and Medicaid waivers. There's no Medicare waivers at this point. However, these New York and Washington both have said that they can achieve their plans even without waivers. For example, the plan could be set up as a Medicare Advantage provider to be able to, bring the Medicare dollars in and incorporate Medicare. So there's been a tremendous amount of work done on this. And, also Canada, I think most people know Canada initially passed it province by province as well. So there is a basis for, a precedent for this type of thing. Thank you so much. I hope I didn't go on too long.
Thank you.
No, thank you. Delegate Bagnall has a question.
Thank you, Madam Chair, and thank you to the bill sponsor. I don't know if you saw some of the opposition, but I wanted to give you an opportunity to respond because some of what I saw was that we can't afford to do this right now. So can you just clarify for the committee that this is just setting up the commission to consider universal health care. This is not establishing universal health care in the state of Maryland. Is that correct?
That is absolutely correct. This is just a commission. There is no large fiscal note, and the commission is charged with looking at the funding and how that would work, and whether we could afford to do it and how we would be able to handle the funding to be able to afford that. But again, so there's the cost for this commission. The fiscal note clarifies would just be whatever whatever consultants the commission decided to hire would be the only cost of this bill. The Kirwan Commission, I think, spent about, I had that number, I don't have it in front of you. I think it was about $250,000 over the several years that it worked. And in talking with MDH, they think that this would probably be equivalent, although that's not in the fiscal note, that's not an official statement, but so it wouldn't be a huge cost for the commission, and their work would be, to figure out if we could afford this and how to afford it. Thank you.
Thank you very much. Thank you, Madam.
Thank you. I don't see any more questions for the proponents, so let's move on to the unfavorable witness, Vince McAvoy.
Thank you so much, committee. I appreciate this. Of course, we know that healthcare is related to substance abuse. We had talked about that this week. I refer you to the video, Seattle is Dying, a 1-hour video about how drug use has destroyed the former liberal Emerald City. It's a very sad tale about the costs of healthcare. And while Obamacare was sort of ACA was being swept into Maryland, people in the healthcare insurance realm did tallies on what it costs in Maryland for healthcare. And taking aside maternal, 4% of Marylanders incur about 80%, just over, of the healthcare dollars in the state. And those 4% are drug addicts, the obese with diabetes, and other bad actors who are not taking care of their health. That's why I'm against this bill and why these type of things never work. these things have been having trouble in homogenous societies such as Northern Europe and in Japan. In melting pots such as ours, we can't even decide on what is male and female. So to try and push universal healthcare in this state would be too costly, would not be long lasting. And we'd find soon that we're having the same type of problems that UK is having, where they still have it and they call it, and they're very, very pleased with the banner, the branding. Unfortunately, every year they have to deprive more and more services. So you have elderly dying. When we have a situation, when we have a culture where doctors feel entitled to make hundreds of thousands of dollars, pharmaceutical companies have no problem peddling vaccines that are basically killing and giving myocarditis to our youth to make tens of billions of dollars, we're just not going to have health equity. But what we could do, just in closing, let's picture what this would be like if we had $0. What could we do? And that's improving our healthcare. That's getting more people in the community to helping out on a per block area. And I think that would be a thing that we can do now for our people that would help Maryland. Thank you for your time.
Thank you very much. We have a question from Delegate Bhandari.
Go ahead.
Yeah, thank you, Madam Chair. This question is to Mr. Baines.
Hi.
You know that Mr. Baines, like we always work, and the Maryland General Assembly has significantly increased access to health service for Marylanders, but these efforts have not resulted in universal access to healthcare. Like, you know that employers sponsor health coverage continues to decline, premiums continue to rise, and why it is a bad idea just to study and just to research which way we can go and help every single vulnerable Marylander. And you are talking about the cost. Life is important than the cost. Why you don't like the idea of just studying?
Same reason we don't study alchemy anymore, Dr. Bhandari, is because we know that it led nowhere. We can't make gold out of nothing. And the problem is that we have disparate ways of going about things and disparate ethics. When we don't have people who will honestly take care of themselves and honestly take care of their children, and as I see in Baltimore, which are, and you went to UMBC, these are horrific cases. So what do you do with that when you can't get people to say, this is a bare ethical minimum, bare spiritual minimum, and will go no lower, no matter what? What do you do? Well, basically you keep throwing money at it. If Maryland wasn't as rich as it was, we'd never even have what we have. It's just, we're a rich state. That's why we get away with these kind of fantasy unicorn ideas. But if we were a poor state, we couldn't do half of what we even attempt to do and fail. I think that we have gone into the realm where we have reduced stigma. We thought we were helping, maybe. I don't know if that's the case, but we thought, some people thought they were helping. Look, it's by holding people accountable to that bare minimum, and we'll drop no lower, that we can go higher. That's a bare minimum. That's not, the legal standard is not what you shoot for. We are a long state with an incredible history. Things that Marylanders have done have been amazing. But now we're just like whatever, the bare minimum. You know, potato chips, frappuccinos, you know, weed and porn, and we're just happy. You can't live like that, and you can't continue to fund that. We must have a bare minimum that we hold each other to, and it's work. And I think that's why, doctors, because sometimes we think that we don't have to do the work, and we always have to do the work. And look, kudos to you all for being there so late.
We have a question from Delegate Bagnall. Can we go to Delegate Bagnall's question?
Sure.
Go ahead.
Thank you, Chair.
Thank you, Madam Chair. And I'll be very brief because I know this is standing between us and the end of the hearing. Just for the record on this hearing, Mr. McAvoy, can you just clarify, you're speaking on behalf of you as a consumer and not on behalf of any organization? Is that correct?
I always.
Okay, thank you very much.
Always speak on myself, for no one else.
Thank you so much. That is the last question for this panel. So that concludes the hearing on House Bill 610 and the work before the committee today. We will be in hearings tomorrow.